moderate the next, the first sessions, and if I may invite Dr. Mahmoud up on the stage, so the moderator will introduce him to the audience. Dr. Shireen, تفضل. جايك.
Assalamu alaikum wa rahmatullah. Good morning, everyone. It's my great honor to welcome you to the second day of the second International Conference on Strategies for Effective Interprofessional Education and Collaborative Practice, organized by KKU in collaboration with NIC. My name is Yahya Asiri. I'm an associate professor at the Department of Pharmacology, College of Pharmacy, King Khalid University. Our first speaker is Prof. Mahmoud Adel, who is a clinical professor at clinical professor and global data and digital health lead, School of Medicine, Qatar University, Doha, Qatar. Welcome, Dr. Mahmoud, and the floor is yours.
Honorable guests, respected faculty, colleagues and students, Assalamu alaikum wa rahmatullahi wa barakatuh. Let me say thanks to Professor Ali Kahtani and Professor Muhammad Al-Naimi to hosting this conference, and thank you to KKU University, because the purpose of this conference is that how best we can share the experiences and knowledge in order to improve the effectiveness of our students and of our trainees, as well as our faculty. And the purpose is how best they can save more lives and they can improve the outcomes, as it is very clear that anyone who saved a life likes saving the whole humanity. So I think with that notion, I would like to start sharing my experience on the data and digital front. And I have seen the countries around the world that how best they are dealing with it. And I think I would like to share some of those things with you. Let me say, if the key purpose of today's inspiration is that how best we can use technology to improve the interprofessional collaboration and interprofessional education, I have highlighted the word health in red, because we need to remember health is physical, mental, and social well-being, not merely abstinence from disease. And when it's about health, you cannot deliver health at your own. You need to have interprofessional collaboration. And then the success criteria for the healthcare workforce needs to be very, very clear. And these are the criteria for the success of the health workforce, that people should be a patient and population living longer, living healthy, and we should be using our resources in an efficient manner to deliver effective and safe care. Let me talk about a few of the trends globally which is happening. The first big trend is that we are moving away from healthcare to health. We are moving from patient to population care. We are moving from curative to preventive. And we are moving from a hospital with wall hospital without walls. And of course, congratulations to Saudi Arabia having the biggest virtual hospital in the world. And then we are keen that we should be talk about value, not about cost. The graph on the right-hand side show what has happened in the last 110 years. So if you look at what was the causes for mortality in the year 1900, you will see that the top 3 causes of mortality were pneumonia, tuberculosis, and GIT infections. And then if you look at the other graph, which is from 2010, it looks like that people are dying because of either cancer or ischemic heart disease or stroke. At the end, it is 75% of the mortality now is because of the chronic diseases. So this gap means that we need to think that the workforce which was helping to save lives almost 100 years back, their training was very different than the training we need to have now because our challenges have changed. So here is a question for you. You need to think and ponder that what is the burden of disease in your country where you have come from? Because that is the first thing we need to be thinking, that if we have to deal with health, that what are the challenges my country is facing? As I am in Saudi Arabia, so here is the data from Saudi Arabia. So this data has been collected globally for all, which is very advanced in the 21st century, we are able to get it. Third one is the lifestyle data. Many countries started collecting it. Scandinavian countries are very, very good in that. So we are doing it in the UK as well, so the lifestyle data. Then comes the social determinants of health data. To me, that is the most important set of data. Reason is this: if you want to improve health, then everything else I mentioned before is only contributing to 30 to 40% of health. Social determinants is contributing to our longevity and to our health outcomes almost 60-65%. There are various studies being done from Canada to Singapore, and then the conclusion is the same. That is the broader determinants of health. How much that data is being collected? Here's an example from Scotland. One of the previous role was I was medical director for Scotland, and one of the national responsibility was to have all the data, and we use the data to improve health outcomes. And this is what we developed. So the whole country being divided into 9,766 data zone. Each data zone, there are 750 people live, and we have the data on the broader determinants of health on those 750 people, where they employ. Of course, it was confidential data, not by individual, it was anonymized. But if someone, and we used that data very effectively during COVID period, because we knew where our vulnerable population is. And this was the beauty of that data. Right, data is not good enough. We need to change the data into health intelligence, which doctors, nurses, pharmacists, the public health physicians, and everyone else can use. And this was the model we utilized. I worked with my team to develop it, and it is basically to collect the data, link the data, analyze the data, put the context to the data, and that is where I put in red interprofessional collaboration. In my team, there were 150 professionals, healthcare professionals, and I had 300 data analysts. 150 means doctors, nurses, pharmacists, physiotherapists. At that point, they were giving their valuable knowledge that what is relevant for that particular patient or that particular population. So that is the beauty of interprofessional collaboration, even at that level we were doing. So those 150 people work together, not just the doctors. They all work together in order to change that data into applied intelligence, and that's what we use, and I will show one example later. So again, digital health. I think I always like to have a common understanding with a common definition. So this is the standard definition, which is from WHO or a number of other organizations. So it is the data and information technology which can be used to improve patient and population outcomes. So that is so-called digital health. But what it entails, so that is an ecosystem of digital health. Different countries have got different parts. Look at the top in the middle. almost every country has got EHR, electronic health record, because as I said, countries started collecting clinical data first. So and I personally like to use the word EHR, not EMR, not electronic medical record, rather electronic health record. That is again another notion how best we can have a collaborative approach. So every profession should be able to put the relevant information into the record of the patient or to the healthy person so that it could be used subsequently. And then we have telemedicine, virtual apps, communication, virtual reality. But basically, it's a plethora of things which all called so-called digital health. Then we all know the digital revolution actually happened during COVID times. Sadly, so many people passed away, and that was the biggest dent to the humanity. But on the other side, for the coming generations, we learned a lot from COVID. And one thing we learned that how best we can use the so-called digital medicine. And now 10% of outpatient appointments in USA and in UK and many of the European countries are happening through telecare. I remember having long, lengthy conversation with my hospital consultants, asking them to use telecare, and they said, we don't. We like to have face-to-face patient interaction. And COVID changed everything. Now they do not want to go back. They said, I am achieving the same outcome sometime from my home, and I can run the clinic from my home. And my outcomes are as good as they were before, even maybe better. But of course, there is a digital divide. Not every person, every patient can get and we need to be mindful. And I think there's a lot of work being done about health inequalities, and the data and digital is the biggest cause as well as the solution for the health inequalities. And then at the same time, 44% of the physicians, not all healthcare professions in that survey, said we are not well equipped how to use it. So that is, of course, the focus for today's talk, that 44% of our healthcare workforce is saying that I don't know how to use it, then I think we need to think carefully. So again, two questions for you. The reason I'm putting those questions, because at the end of the day, mashallah, you are very experienced people, and sometimes these conversations basically nudge you that, yes, I need to think on those lines. So the question is that has all discipline integrating EHR education and training in their curriculum? So I'm asking you that think about, if you develop the curriculum, do you teach in pharmacy, in physiotherapy, in occupational health, in nursing, how to use the EHR? I don't know whether you're using Cerner or Epic or anything else, but do they know how to use it? Second question, practically, if you are in a hospital, who is not using EHR among all the healthcare professions in your hospital? Because this is very interesting, because when you look at, for example, in Qatar, for example, in the UK, when I look at the EHR, say most of the information is coming from physicians or maybe from surgeons. Why not other health professionals having their own input? And this means that either we need to change the EHR, so we need to work with the technology company telling them that the physiotherapist is a very important part of the team, why there is not enough opportunity for them to have to put their information. So this is what is happening, and I think that is one of my goals as well, that how best we can move in that direction. So this is, again, I think all of my colleagues and speakers yesterday, they put emphasis a number of times that yes, in this, the tool can help improve communication, enhance patient outcomes, reduced errors, increased efficiency. So I'm not going to convince you because this is given. But this is very important. Let me give you two examples. One is about the virtual reality. So, of course, virtual reality gives us very contextual, collaborative, and experiential learning. But benefits are wonderful because you can work in a safe practice environment, repeatable scenarios, and immediate feedback. I have done it myself with a number of other colleagues, and I think this is the direction of travel. I think yesterday, whoever was here at the end of the day, we had a wonderful scenario. And if that scenario has been done through virtual means, it means everyone should be participating. We are going to do another one today. So, and then it is going to lead to improved teamwork, communication, and professional identity. Then the role of the telemedicine collaborative practice. Again, I mentioned before, it improves interprofessional communication, but the challenges are technology access and digital literacy gap. But benefits are huge, and I think this is working. Dermatology and number of specialities, they're very, very good in this, and they're using it all day round. That brings me to the key point. This is a Decode project done globally. The whole challenge was that if we are so keen on the digital health, what is the competency framework for digital health? And the Decode project, of course, it was used the word medical education. I would change into health education because that's the reason we are here. So, but we do not want to reinvent the wheel, because if the work has already been done, and there are 4 domains, 19 competencies. Domain 1 is professionalism in digital health. Domain 2, patient and population digital health. Domain 3 is health information system. Domain 4 is little bit super specialized, health data science. Not all healthcare profession, health profession need to do that. I think there are very few who are doing it or done it. So I would emphasize that out of those 4, these are the 3 important ones. If you're building your curriculum, you need to be thinking about those 3. And I think this is key, that we should be keen on the digital literacy. We need to think about what are the different tools available for patient population outcomes, and how the health information system work. I given you the example of EHR. So these are the competency frameworks available. Decode, if you put the word decode, you can get it. Then when we say about literacy, it is the ability to access, understand, use, and share the digital tools and data. And this is the minimum we should be expecting from all health professionals. Ability to access, understand, use, and share. So I think that should be our minimum goal. And here are a couple of stories or the case studies which are positive. First one was Oklahoma from America. 7 institutes, 1,800 students. They work on the IP, on the virtual setting, and the outcomes were excellent. So it is proven. Second one was Singapore, where the doctors and nurses, they were given the platform for the virtual platform, and the patient's error gone down, and their communication went up. And then one example from Scotland, I think we were personally very proud that there are 29% of the children in Scotland are obese. If I'm here in Saudi Arabia, the numbers are very high. Same as in the Middle East, just for a number of reasons. 29%, it was pretty high. When we looked at where they are, do you know the map of Scotland? The darker the color, the more obese children are living over there. Then what we did, we asked that from all the schools, I asked the team, map the whole country and figure it out that how many fast food restaurants are within 15 minutes walking distance. In the UK, the secondary school children can go out during lunch break and they can eat out. Then we worked with the school nurses, asking them that give us the data that how many people are having mental health issue and number of other things. This is the map of the top 5 or 6 schools which have got the highest number of a fast food restaurant within 5 minutes walk. I gave it to the Minister of Health. I said, this is the state of the play. This is the reason the children are getting very obese. They changed the policy and the laws. Now the law has been changed by that interprofessional collaboration that in all the new schools, there is not going to be any fast food restaurant within 15 minutes of walking distance. This is happening in Birmingham. This is happening in London. So this is the example where they use the data, interprofessional collaboration, to change the policy and having an impact on obesity. Artificial intelligence, don't want to spend much time on this. Alhamdulillah, I had the opportunity to develop the national policy. We worked on the regulation of artificial intelligence and then, of course, the implementation. But the question is, artificial intelligence is reality and we need to embrace it. And then diabetes, again, as I said, it is one of the most prevalent causes all across the globe. If we are dealing with diabetes, there are plenty of digital tools and means available to all healthcare professionals. They should use them effectively. So just the last few slides, changing times, changing tools. So we need to move from, look, stethoscope have been our hallmark. Doesn't matter which professions you have, you're carrying the stethoscope. I still have mine somewhere, but stethoscope to data and digital scope is the journey we need to do, because this is what is the future and we need to embrace it. And this is another thing to reflect. This is a question we need to be asking at the end of the conference, that do current health training programs incorporate enough data and digital health knowledge and skills? I already mentioned about Decode project. We need to do something. King College University could be the pioneer, and maybe other universities. So if I have to write the prescription for success, that would be my prescription for success. Digital health technologies are essential enablers of modern interprofessional education. Successful implementation requires comprehensive planning, training, and support. You can't just plan and leave things there. You need to do the training, and then you need to provide further support. And when we have our interaction with the patient, I always ask my clinical teams, ask two questions. Is patient using any digital tools? Because when I was in the medical school, I was told how to do the history of the patient, right? But now, I think we need to change that. In that history, apart from all other things, we need to ask, because everyone is carrying phone. Are you using any app which is going to help you with your lifestyle? Can I access that? Now we can do that. And the second, think from your side as a practitioner, are there any tools? If you're a physiotherapist, for example, in the UK, we have got a number of apps being approved, and the physiotherapist can prescribe them. So can you prescribe a digital app? And I think we need to be thinking on those lines. Then if you are an educationist,
Excuse me?
you need to think about digital health competencies must be core to all health professional curricula.
Excuse me, Dr. Adil.
And if you are faculty, students, trainee, you need to build your competency and special interest in clinical data and digital health field, because it can augment your career. Because people are saying that, yes, we can't stick to the same career going all of my life, then here's an option for you. And then if you are a leader, as part, you can influence things in the whole country, you need to aim high. And if you aim high, you need to make the biggest difference which you can improve in your country and beyond, so that you can use the data and digital in the most effective manner to achieve that goal. So this was the prescription for your success, my success, our success, Saudi success, and Annex success. And inshallah, we will make it. Thank you.
Thank you, Professor Adil, for this insightful presentation. Allow you to, if you don't mind, to have a seat here, Dr. Mahmoud, or afterwards. So next to our co-moderator, Dr. Mohammed Dahaim, he will be presenting our next presenter.
Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, it's my great pleasure to introduce our next distinguished speaker, Dr. Barbara Maxwell, a global leader in interprofessional education and collaborative practice. Dr. Maxwell served as the Associate Dean and Executive Director at the Indiana University Interprofessional Practice and Education Center, and is a professor of physical medicine and rehabilitation at the Indiana University School of Medicine in the United States. With an impressive career spanning education, research, and leadership, Dr. Maxwell has been instrumental in shaping a model of interprofessional collaboration that bridge academic learning and clinical excellence. Her work emphasized teamwork, mutual respect, and evidence-based strategies that enhance both healthcare outcomes and professional development. Today, she will be presenting on a topic that challenges our assumptions and deepens our understanding: interprofessional practice and education, myths, misconception, and misdirection, seeing through the vogue. Please join me in welcoming Dr. Barbara Maxwell on the stage.
Assalamu alaikum. Thank you so much for the opportunity to talk about something which I am very passionate about. It comes from many years of experience. So I'm in my 4th decade of interprofessional work, not as much as Dr. Gilbert, but I'm trying my best to keep up with you, John. And over that time, I've been lucky to work on 3 different continents in interprofessional work. And so what I share with you today about these myths and misconceptions and misdirections comes from that experience of seeing how this has evolved in different settings over many years, and also a deep understanding of particularly the literature, the foundational principles of interprofessional work, and also the theories that underpin it and where they come from. I'm going to unashamedly challenge you with some notions about rethinking some of the assumptions that you have about interprofessional work. And I am paying tribute to the ABBA Fog Walk. When I knew I was coming here, I chose the theme of fog because to me it was so applicable to ABBA, but also to the notion of sometimes the things, our assumptions, the things that we believe, the things that we hold to, our norms, how we do our own work, what we are as an individual profession. It can leave a shadow or this fog over what it really is that we need to do in interprofessional work. And so that's what I hope to share with you today. So let's take a look at the fog. Let's take a little look into it. I'm going to share with you that I think the fog sits in three very distinct areas. At least some of the fog I'm talking about today does. The first is that it's about the scientific basis. Lots of myths, misconceptions about the scientific basis of interprofessional work. Also about the nature and the structure and how we go about interprofessional education. And the third is about practice. And I'm going to ask you to participate a little bit with me as we talk about each of those. So I'm going to share with you on screen some things that you may have heard or that you may have actually articulated yourself about interprofessional work. And I want you to raise your hand if any of the things that appear on screen you have uttered yourself or you have heard others utter about interprofessional education and collaborative practice. So here's the two for the scientific basis. So if you've heard this uttered about interprofessional work, raise your hand. Okay, we've got a lot of good hands coming up. So this assumption that it's soft science, that it's lacking in evidence and theory, and it can't be properly researched. Some other myths about education. What about these? Have you heard these or uttered them yourself? The hands are going up. Yep. So, interprofessional education, I found it really interesting that in America, at the same time that interprofessional education entered accreditation standards, so did education on genetics. So what did we do in the US for genetics? We treated it the same as anything else in the curriculum and hired faculty, used the structures within the university to fund it. We had students come into it in exactly the same way. All the processes were the same as every other piece of their curriculum. But interprofessional education, we stuck it on the side and asked for volunteers. Why, if it's required curriculum, would we put it over here, make it voluntary, and ask for volunteers? What makes our mind think genetics is normal? Interprofessional education's this thing over here. The more we talk about it as activities, as something extracurricular, something out there, takes away from it being in the core of a curriculum. So a lot about the language that we use and the steps we take to deliver it, you know, that optional volunteer, it's about events. If it's about events, are we doing lots of with each other, but not from and about? And the notion that IPE is synonymous with case-based learning and simulation, rather thinking that simulation and case-based learning is a tool through which to deliver interprofessional education. And also the notion of traditional education, where traditional education focuses on what goes into the curriculum. So you'll hear comments that it's too difficult, we don't have time, the curriculum is already too packed. And yet interprofessional work is examined through competency. And competencies are educated in a different way using competency-based education and looking for behaviours. So we're using methods of traditional education that don't necessarily work for competencies that we're aiming for. Okay, and in the practice world, have you seen these things? Again, raise your hand. Yep, lots of people responding. They're the common things we hear, the challenges we have. For, like I say, I'm in my 4th decade of doing this, and the number of times on a monthly, weekly basis I have to address these, even almost 40 years on from when I started. So that notion that we already do this, and the misassumption that if you're co-located in the same place with other people, that you necessarily work well together. There are places where people do, but many where they don't. And that it doesn't apply to my work or work setting or profession. A lot of the evidence for interprofessional education actually comes from the social world, from psychology, from anthropology. That is not our world. And because we don't understand that, we think it belongs to health. But interprofessional education and collaborative practice are underpinned by science that comes from elsewhere. So I want to give you a little clarity. So I've told you some of the myths, and I think most of you agree with me that you've heard them or that you've said them. So let's see if we can see through the fog, have a little bit of clearing. So how can we challenge and think about these myths and misconceptions? I want to argue that if we think of interprofessional education and collaborative practice as complex social interventions rather than health interventions, we can actually understand the nature of what it is. Complex social interventions are things that you do in already established social systems that usually are the cause of the problem that you're trying to solve. And they change over time. They're flexible, adaptable. What you intended at the beginning doesn't necessarily look the same when it comes out the other end of complex social interventions. And also, when you think about the intent of it and measuring the intent of it, the measurements of complex social interventions take very different methods. So think of it as a complex social intervention, not a health intervention. We are actually rich in theory, really, really rich in theory. But you'll often hear people say there's no theory for interprofessional education. But there's really robust theory from anthropology, sociology, cognitive sciences, systems science, so many, team science, so many places where that evidence is really, really strong. So the last one I want to share with you on this particular slide is collective competence. I want you to really think about what the intent of interprofessional education is. Is it to reach these competencies, or is it to add to what you all do in individual schools and programs to make individually competent practitioners? There's a second layer that is the interprofessional layer, which is to develop collective competence, because it's in the spaces and places between individually competent healthcare providers, social care providers, population health. In those places and spaces between is where the errors happen, where care quality falls off, where poor communication sits. So I believe that interprofessional education, using Lorelei Lingard's work on collective competence, our goal is actually collective competence. The competencies that are described should tell us how to get there, but our goal is collective competence. I want to talk a little bit about signature pedagogy. So we all know kind of the way that we work, the way of our own professions, but signature pedagogies have been studied by Lee Schulman for many, many years. And signature pedagogies, Lee Schulman studied them in different professions, in the ministry, in health, in medicine, to try to see what the underlying perspective and way of being and doing for health professions were. I'm going to read exactly from Lee Schulman's description of a signature pedagogy, and think about it from your own professional perspective. So signature pedagogies implicitly define what counts as knowledge in a field or profession and how things become known. They define how knowledge is analysed, criticised, accepted, and even discarded. They define the function of expertise in the field, the locus of authority, the privileges of rank and standing. They even determine the architectural design of educational institutions, which in turn serves to perpetuate these approaches. So they are self-sustaining and pervasive, our professional pedagogies. And so recognizing that, when we step in and try to do work where we're focusing on interprofessional learning and a complex social intervention, or we're trying to study it, we use the methods that are common to our own professional signature pedagogy. And that leads us astray, because interprofessional work is a complex social intervention, and it needs different methods to look at it. So there's a reason why systematic reviews tell us that it's all just too different. We can't pull it together. It is different because it's complex social intervention that is very context dependent. And when we embrace that, we can move forward. Thinking of the competencies are observable behaviors. So if you're measuring interprofessional effectiveness, particularly in education, you want observable assessment tools. Observable. Attitudes, if the student like it, good, but they can still learn when they don't like it. In fact, they often learn best when they don't like it, when it's hard and difficult. So observable behaviors. Think about that. What are your observable competencies, behaviors? And what are the attitudes, knowledge, skills, and behaviors that are contained within collective competence? If it's a different layer on top of your individual professional competence, what are the attitudes, knowledge, skills, and behaviors, and are they articulated in the competencies? And then intentional design and intentional action. Those who say that we already do this in practice, and they probably do not, are assuming that they do because they're co-located. But what interprofessional work in practice takes intentional, willful action. We're trying to train human behaviors. If we could buy a machine that would cause the same effects, get the same outcomes for patients, for costs, for the health and well-being of the workforce, we would buy that machine. But the machine is us. It's our behaviors as health professionals, and that's incredibly difficult to change. So start thinking about behaviors and intentional action to see and embed those behaviors. That requires an attitude change. So it costs too much. We don't have enough time. All of those things, I would say, are an attitude set. We can come up with many, many, many barriers to interprofessional work and interprofessional learning, but they come from an attitude. I have a friend, and it ages me when I say this, so I know that. She always says, show me your checkbook. Who has a checkbook anymore? Show me your checkbook and I'll show you what you value. If you don't invest in interprofessional work, it indicates there's a lesser value for it. So we have to work really hard on why this matters. And we have to get that value and that attitude to be able to be sustainable. And then we do have to recognize that there are system issues that shape and limit our capacity to engage in interprofessional work and interprofessional education. Yesterday we heard from speakers about siloed education. You heard about the signature pedagogies and the architectural impact of that, where we work and live in different buildings on the same campus maybe, but we're segregated because that's what our signature pedagogy has us do. We know there are system issues, but there seems to be a misconception that they are immovable objects. They are not immovable objects. In the pandemic, we saw systems shift overnight. Things that we thought would never change with regulation, with the processes, with the things that we do, the access to telehealth for people that was mentioned earlier today, all of those things happened overnight because we were responding. System issues can be addressed. They're not immovable objects. So I know it's been a fast speed through a lot of myths, misconceptions, and misdirections, but I'm hoping that it will clear and make you start to look at clearing some of that fog that covers over and shades our view of what interprofessional work is, about how we do it, about our assumptions when we step into it. Start to really think deeply about your own signature pedagogies. What layer of fog is that producing? What assumptions is it creating? And hopefully, if we start to challenge these myths, misconceptions, and misdirections, we'll be able to see a really clear path ahead for interprofessional work. And that path might be winding, like the roads in Abba in the mountains, but it will get us to a better destination that's not fogged up with some of the baggage that we bring from our myths, misconceptions, and misdirections. Thank you so much.
Thank you to Dr. Barbara Maxwell for this interesting and wonderful presentation. Next, we will move to our
Okay. Assalamu alaikum. Assalamu alaikum. It's working, yes. Assalamu alaikum. Yes, assalamu alaikum. It gives me a great pleasure to be with you today. I'm really honored for the Scientific Planning Committee, for the wonderful organization, for the welcome and the hospitality. My name is Dr. Shireen. I'm a senior consultant of internal medicine at Hamad Medical Corporation. I'm leading the GME office as the Associate Director of Medical Education at HMC. Would like to introduce the next speaker. Our next speaker is Dr. Siraj, or Professor Siraj Ali Mahmoud, and he is a professor, he's the head of the Department of Medical Education and Professor of Microbiology at the College of Medicine and Health Sciences at the University of Science and Technology at Sultanate Oman. He's the founder of a fellowship program with the FAMER, which is called the MAHI, which is a 2-year fellowship, an innovative, actually, fellowship program, which developed with the Foundation of Advancement of International Medical Education and Research, which is the FAMER in Philadelphia, and which is dedicated for interprofessional leadership, IPE, and interprofessional collaborative practice globally. He's going to talk to us about, it's easy for us to start IPE or interprofessional educational initiatives, but it's really difficult to sustain it. And this depends on the strengths or the tenets of strengths-based leadership, which is his talk. Please welcome with me Dr. Siraj Ali.
Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala ashrafil anbiya wal mursaleen. Sayyidina wa Maulana Muhammad. Wa ala alihi wa sahbihi ajmain, amma ba'd. Honorable dignitaries, fellow faculty, colleagues in ANIC, and my dear students. Greetings from Oman. I represent College of Medicine and Health Sciences, National University of Science and Technology. Can we have the slides? But the story that I'm going to share with you today is from India. How we designed, developed, and sustained a center of excellence of leadership in interprofessional education, following the tenets of strength-based learning. We want to present this case study to you as a typical example for innovation in leadership and governance. The MAHE FAMER Institute, which was located in the Manipal University, a world-class university from India. As the title reads, Leading Beyond Boundaries, Building IP Excellence Through Strength-Based Leadership Approaches. It challenges the traditions of our approach to systemic improvement which has been defined by identifying and fixing what was broken. The question before us today is not how to fix more problems, but how to activate phenomenal strengths that already exist within our organizations and communities. The philosophy guiding this activation is strength-based leadership, and the approach is rooted in positive psychology. The philosophy guiding this, as I told you, being strength-based leadership, it actually looks at capabilities of human beings and organization to improve performance and engagement. So it's a developmental approach that actually redefines the whole concept of leadership. So if you look at this, these are the 5 pillars which forms a framework and assesses the readiness of the organization for a systemic change. It starts with purpose. This is more than a mission statement. It's a clear, shared vision that actively inspires collaborative action. People, it's about leveraging their differences, fostering purposeful relationships, and promoting inclusivity. And you know that every change requires structure. That is the process, establishing effective, transparent systems and routines. Perseverance is ongoing commitment required to sustain action, and passion is the necessary emotional, motivational fuel that drives engagement and co-creation over the long term. So today what I'm going to take you through is 3 important approaches that we used as a part of strength-based leadership to develop this institute. You can see asset-based community development, the power of positive deviance or the positive deviance, and appreciative inquiry. As observed in organizational psychology, when institutions exclusively focus on deficiencies, they inadvertently become highly sophisticated at detailing those failures, often at the expense of recognizing potential. The pursuit of identifying what went wrong is a necessary function, but when it defines organizational culture, it will stifle innovation, it will discourage risk-taking, and ultimately will deplete the very human resource capital we rely upon. So the more you face on the failures, as the code says, the more you know about what is going wrong in an individual's life or an organization's life, the more it makes you an expert in failure. So in this presentation, we will see how these strength-based approaches were aligned to develop an institute of excellence focused on interprofessional education. We start with appreciative inquiry, the 5D process, what works well with people and organizations. Evolved from an academic theory, is a very powerful tool now. It's an influential methodology for positive organizational change. The first D is define, that establishes the strategic focus, where you clearly say what is the purpose of the institution. The second phase, the second D, is discovery, where you value the best, what is at the heart of the strength-based approach. You try to see what works well in your organizations, what your people are good at. So it is by uncovering what you call the positive core. So discovery identifies the positive core of the organization. Third is the dream phase. With this positive core, where do we reach? Means imagining the possibilities, generating a shared vision for the future that is ambitious and motivating. The fourth one is design. Just dreaming will not help. What could be? The design phase translates the aspirational vision to actionable strategies. And finally is destiny. That is nothing but sustaining and institutionalizing what will be. The final focus on turning the structured design into real, tangible actions. That is about appreciative inquiry. I'll take you through the processes that happen within the institute. The second approach is positive deviance, and the people who follow it are positive deviants. It came from nutritional research when, Sternins, it was a study, WHO-funded project, and when they found that the money or funding stopped, this was in Vietnam, they had to see alternative methods to see how you address the problem. The positive deviance, in a nutshell, is there are people in every organizations, in every setup, who do really well in spite of all the difficulties. The opportunities are the same, the challenges are the same, but you will see that these people or these organizations do really well. So these are outliers. They do things in a different way. So positive deviance is a science where you go and identify it, determine the outliers or people who are doing that, discover that behaviors, integrate that into the system, and try to replicate it. The Power of Positive Deviance is one of the phenomenal works that has been published in this. So that is the second approach. The third approach is about asset-based community development, which is very common in many of our settings, but we really don't call that. It basically looks mapping the skills and resources already present in the team, building the trust and mobilizing these assets towards a shared vision. So these three, basically, if you look at, you can see that there is empowered delegation and shared leadership, and everyone takes ownership of results, making the organization more resilient and effective. It was started as an approach early 90s in undeserved urban neighborhoods in the United States, but soon it became one of the very important aspects, especially when addressing community-based developments. So to begin with, we actually made the commitment, as we call iltizam, right? Which basically focused on all these aspects. So we had around 24 centers, like in your campus you have many schools. We had 24 schools and around 1,400 faculty, 1,400 faculty. Today it is 39 schools and 3,000. That is how it has grown in the last 10 years. But we called each of these people from each of these institutes, and we had this commitment made before we started the institute. So collaborative engagement simply means building teams around their individual strengths. Each institution was known for their own strengths. Each individuals in their organizations had strengths. The second aspect was to clarify the focus, align the institute's goals with the members' core strengths to create clarity and shared purpose. Then we had facilitating co-creation, which is to assign roles based on the talents to promote creativity, ownership, and so on. Finally, we had open discussions that spotlight the strengths, helping the members to learn from each other. Once the stage was set, we defined, as you see here, as a part of appreciative inquiry, we defined a clear and inspiring purpose for the institute. We had a shared vision for strategic direction aligned with the mission of the university. That is something that we had to be extremely cautious about. Your visions should not collide, or it must actually align with the vision of the university, with the university mission. So key affirmative topics, what is there to be discovered in the exploratory phase, so the discovery phase was identified. So after this, we went on to the discovery phase. In the discovery phase, what we did was, for uncovering the strengths, we did appreciative interviews across the professions. So we had people from the School of Medicine, from Allied Health Sciences, from the School of Engineering, a number of the schools that we had in institutes, and we conducted interviews across the professions. And these are known as appreciative interviews. A gist of it is like this. We asked them, can you recall a time when you felt most engaged and effective in this organization? What do you value most about your work or team or institution? What factors contributed to the success? So you can see that the entire thing is highly appreciative. And we also identified positive deviants in these organizations who made a difference in spite of all the challenges they had. So this was the discovery part. After defining, we went to discovery. Whole idea was basically using storytelling and focus groups. We captured themes of success to identify what is the positive core already present in the organization. After defining and after discovery, we had to move on to the next phase. That is obviously in discovery, we had a collection of stories with shared understanding of strengths, networks of stakeholders, and the positive core. So that was most important for us to see that where do we stand in terms of the strengths of the people, who is good at what, So with that, we moved on to the next phase, that is the dream phase. The dream phase basically looks at two important activities that we did. We asked people to envision the future, and also there is the second one is the history of the future. So storytelling and vision boards. We used two important aspects, two important methodologies for this. One is visualization of the future. With all these good things, with all these good people, with all these good things in place, where do we see in the next 5 years? Or where do you see this institute in the next 10 years? So that is envisioning, but it is just not a mad envisioning. You put a timeline to it, you work backwards, you have the milestones attached to this. So basically, if you look at this, the participants used to share stories and visualize the organization's future using images and collaborate collectively what could be. So we used two important strategies, one storytelling and vision boards, and then aspirational vision statements, which was crafted bold, future-focused vision statements about how motivational it were and how these were aligned with the dreams that we had. So our dreams generated a shared vision for the future, a set of strategic aspirations, stakeholder commitment, and a roadmap that goes to the next phase, that is the design phase. So in design phase, vision to actionable strategies converted the aspirational goals into the practical steps. We defined or we refined the frameworks in organizational structure, that is what we do. We designed or refined the frameworks for decision making and communication. And obviously, we had to look for the curricular integration, looking at what's happening in the different parts of the world as far as interprofessional education was concerned, ensure learning and development activities that reflects our institute's new direction. Most importantly, as you heard even in the previous speaker's talk, it was important basically to have a research focus, prioritize the investigations and innovation in key areas, and most importantly, funding, from where does the money come? Because even for the deans and vice chancellors, if you're actually going to do this, you must find your own source, right? So it actually identifies and secure the resources that are necessary for sustainability and advancement. Finally, the most important, perhaps the most important told thing in this conference would have been the last thing. I heard from people talking about faculty development. So it was important, how do we actually prepare? How do we invest in faculty capacity to actually do these things? So with all these, we move to the design phase of it. We use the pull strategies. People who are familiar with change management, you know there is both the pull and the push strategies. The push strategies actually drive change. It's top-down, often using authority. It mandates it. But we preferred a pull strategy. Pull strategy basically is to engage people, connect them with the upcoming change, provide them opportunities to change. So tap into the energy that was already in play. IP Global was already there. We had to connect with them, Interprofessional Global. And we also had the National Medical Commission actually asking for more teamwork competencies to be built into all health professions curricula. So that was an opportunity. Join with existing groups, events and processes, aligning with larger forces. I told you, this also included some of the regional and global networks. Looking for opportunity windows, as I told you, every vice chancellor or dean is interested to generate income from their own institute. So we developed our own fellowship courses. We developed our short-term courses, which generated revenue as a part of this fellowship. Give voice to the change story. We asked all our people to disseminate this through their own channels. So pediatricians use their own way in their own, organizations. Anatomists had their own way of disseminating it. So each one had their own professional bodies through which they disseminated it. So that moved us to the next phase of destiny, a sustainable, continuously evolving center for the excellence of, in IPE with structured governance, programs, and other aspects, including campaigns. So when you talk about destiny, what we look at today is a sustainable, continuously evolving center of excellence. For the last 10 years, we have sustained it. There is structured governance. There are programs associated with. There is research that obviously is of a high-end research that has actually provided enough evidence in the region related to interprofessional education and policies. We also aligned with the strategic priorities and policies of the university, and it is now developed a recognized hub for the interprofessional education and research activities. Many of those have developed centers of excellence actually stemming from this institute, which is related to enhancing health outcomes. So last year was our 10th anniversary. So in this 10th anniversary, you can see this is the first batch, and you can see the current batch. Why I put this is because in the first batch, probably I'm going to actually highlight, you identify this person. In the first batch, we had Dr. Mohammad Al-Nami graduating and doing this fellowship from interprofessional education. So you imagine every year 20 Al-Namis coming out of this institution and what change it can make. So there is a testimony to what has happened of the institute, just showing that, how people who were linked with this institute were associated with driving change in interprofessional education in their own regions and sometimes even globally. Well, as I want to conclude, I just want to tell you the secret of change is to focus all of energy not on fighting the old, but on building the new. That is what exactly we did. We didn't bother what was there already, rather than spending time and resources on fixing outdated processes, habits. Successful organizations, I believe, must direct their effort towards creating positive, future-oriented solutions. And before I conclude, I also want to tell you one of the frameworks that we used in change management, the SWITCH framework, which talks about there are 3 elements when actually you drive change. One is the rider. A rider is a rational mind. It requires, people ask you, why do you want an institute like this? What is it going to do? How much will it contribute to the university's revenue? What will happen to the, so that is the rider. Then motivate the element, the emotional mind, where people ask, what will happen to me? You are talking about interprofessional. What happens to my professional identity? What will happen to my department? So you got to actually motivate the elephant. That is the carrots that you see. At the same time, you must also shape the path. You must actually provide ideal environment and situations. So by integrating these 3 switch elements, we can actually build change that lasts. You can clarify aims, energize people. So this is just an example. For example, in definition phase, once we had the vision, how did we direct the rider? We gave enough of logic and evidence. Look, this is happening globally. And the university will be able to position itself in a way that it's, whether it is for ranking or whatever it is, it helps. So we made a blueprint like that for everything, where directing the rider, bright spots, motivating the elephant, shaping the path, and that is how we had the blueprint read. Basically, if you look at this, the whole processes that we did was visualizing, as you see here, the metaphor of turning walls into bridges. It signifies a fundamental shift in strength-based leadership, of organizational building, of shifting from individual focus to the collective we.
2 minutes.
So you will see that from what is in it for me, people start asking what is in it for us. So the me to we had very clearly defined as to what the institute wanted to achieve in these years. So this quote symbolizes what exactly the institute stood for. It comes from Lao Tzu: learn from the people, plan with the people, begin with what they have, build on what they know. Of the best leaders, when the task is done or accomplished, the people remark, we have done it for ourselves. So this is the definition of true sustained organizational change. It requires leaders to cultivate an environment where success is not mandated from the executive seats, but discovered and owned at the front line. It demands the courage to step back, trusting the positive core you have identified and built. So, transformation begins not with policies or procedures, but with people who embody the very values they seek to inspire. True leadership is demonstrated through action by aligning intention with purpose and vision with practice. When we cultivate this spirit within ourselves and our teams, we do more than adapt to change. We define it. Our story is a testimony to it. Thank you all.
Thank you. Thank you. Thank you so much for a wonderful talk, for a great journey, Dr. Siraj. Can you join us on the stage, please? I will call the other speakers. Dr. Barbara, Dr. Muhammad Adil to join us. We have 20 minutes for a discussion. We can see the passion, honestly, on this successful journey. Yes. And the thing which I really like about it is that it's really sustainable for 10 years now. This is really great to hear from this experience. We can open the floor for questions. Yes.
All right.
Thank you very much for all the speakers. Excellent, really, presentations. My question is to Dr. Maxwell. I like the idea of this collective competency. And we're dealing in IPE with collective competence. One of the challenges is that how do you assess actually those collective competence, especially when you're dealing with the what do we call it as a soft skills, the professionalisms or communications, and I usually actually I consider them as a hard skills rather than actually, because they are hard to reach this competency. How do you assess the behaviors rather than actually in one spot as an OSCE or as a session? How do you do it actually longitudinal in terms of assessing actually those soft skills or communications of the team or of the in the interprofessional education? Thank you.
So I'll tell you. Hold on. Is it on okay? No? Yes, no?
It's not working. She wants to sit here.
Yay, there we go. So I'll tell you how we do it at Indiana University, because I think the easiest way is to show how we're engaging in it. So for us, we had a very traditional curriculum, and we have really modified and revised the curriculum to a competency-based curriculum. In doing that, we actually developed competency trajectories for the learners. That from the second they enter their own professional program to the day that they leave, how do we expect, and we use the IPEC competencies from the US, how do we expect not just the domains, because when you talk about the domains, they're nebulous, large scale in the domain and hard to measure as a full domain. There are 33 sub-competencies under that actually identify what the behaviors are that we're looking for. So we actually created trajectories for our learners as they progress through the program of how those competencies shape what what it looks like when they engage in those behaviors, and use metrics and measures and a lot of observations of the students actually engaging with the attitudes, knowledge, skills, and behaviors for collective competence. So the hardest part is to designate exactly what that behavior is going to look like. What are you looking for? A way that we've used it in practice is to have the learners who at that stage of competence are not competent in interprofessional work, but they're working towards it. And they're no longer novices. They have the attitudes, knowledge, skills, and behaviors. They've been introduced to the key concepts of interprofessional work. But when they actually come together in practice, we have them at the level there of analysing and evaluating. So the concepts, knowledge, and skills that they've learned as they've been going through the stages of the interprofessional program, when they get to the practice stage, they're actually out in the clinical environments assessing and evaluating the places and spaces where they work on their clinical placements on issues like psychological safety. So what did psychological safety look like on this particular rotation? Or what team skills did you actually see used? What was the type and strategies of communication that were used between health professionals? Did you see those observable behaviors? So not only can you identify what you expect your learners to do, but you can train them to look for those in the environments where they work, with the notion that if it's not there, you can learn an awful lot about why a lack of psychological safety, for example, has shaped the context of the environment you're working in. So it's about being able to get to the level, if you're measuring a competency, it needs to be associated with an observable behavior that you can measure. And at the same time, we use attitudinal tools, we use skill and knowledge performance tools, but we really, the ultimate thing to say, are they at the competency level that we determined? And we used Dreyfus and Dreyfus's model of skill acquisition and the updated Anderson and Crothwell's modification of Bloom's taxonomy to be able to determine what that behavior actually looks like in terms of the actions of the learners. It takes a lot of work, but it's worth it.
Assalamu alaikum. Thank you very much for the impressive presentations. I have two questions. The first question for Prof. Adel. Part of the National Council of Health Insurance, they are started initiatives for part of the 2030 strategies for healthcare, and they started the Clinical Documentation Improvement Program. Now, my question to you, what is your recommendation to have an efficient strategy that will have a multidisciplinary approach when you talk about clinical documentation improvement? The next question is for Dr. Maxwell. What's your suggestion if you have such a huge fog in clinical setting that is an overlapping between quality initiatives and it's an interprofessional education initiatives, and always you have that dominance of quality because decision makers will always look at quality aspects. So what's your suggestion to have a clarity in order to differentiate, or at least let them work harmoniously together? Thank you.
Thank you. Can you hear me? I think the clinical documentation, let's see what is meant by clinical documentation. We need, no, I know. So we need three things for clinical documentation. One, the person who is documenting. Second, the document, whatever the format it is. And the third, the technology. So for interprofessional, we need to look at all those three things. The first thing is the person. So this is the reason I was saying that when we talk about the word EMR, we should be using the word EHR. So that we need to set the philosophy right. So this might be the first thing they should be doing, that they need to work on the terminology very, very clearly, because language is a barrier. So when you start on the wrong footing and by saying that it is a clinical documentation, and you have got a person who's a health professional, is not a clinician, immediately you have got a barrier over there. The person will be switched off. Right, now to come to the second thing. I said the document itself. That is where different countries are at different stages, or different organizations are at different stages. For example, a Great Ormond Street in London, which is very famous children's hospital, they are bringing ambient technology for the whole hospital. Doesn't matter what your profession is. So whenever you're talking, everything is automatically documented in the document. So this is one spectrum, that everything is basically digital. Now you go to the other spectrum, maybe a very old surgery or GP practice in Scotland, everything is on a paper. And then you need to move it, then you need to think about what I mean by clinical document. And the third thing is technology. And I think that my simplest answer is that country, because in Saudi Arabia, there are wonderful things are happening, but one thing is interoperability. So when you as a professional move from one hospital, one setting to another, you shouldn't end up starting training again. And then the last but not least, the universities like this one and others, they need to see what is coming on the horizon. And if they can see this is coming on the horizon, they can inject that in the curriculum now, rather than they should wait that everything should get implemented. Thank you.
And for your second question, it makes me, I'll always give a theory that will help illuminate an area, a thought. So if you think about the theory of planned behavior, Agen's theory of, and Fishbein's theory of planned behavior, it really clearly tells us that, and it's a predictive model, it says if you attend to three things, you're likely to activate someone's intention to engage in a behavior, and it's predictive that if you can do that, they will actually engage in that behavior in the real world, in their practice. The three things are value, attitude, an attitude that it matters what they're doing. And I think often we fail in practice to find what that value is and how to articulate it to practitioners. So it's finding that shared goal that's shared. So when I talk in the hospital system, I use a completely different language than I use when I am in the education system talking about my work. I often ask people, what's your biggest problem that you're trying to address? And we talk about that. Well, it's readmission rates. So we have a talk about that, and we try to start working out why that is. So you have to get that attitude and value. You need self-efficacy. So you need the knowledge and skills that think you can actually do that. And that's, we've heard a lot, and Siraj mentioned it, that need for faculty training or for clinician training. We put so much effort into the next generation of care providers, but what have we done for the current generation of the people who are doing the work? And then we tell the new next generation, who are 3% of the workforce with no power and authority, that they're going to fix all the system issues that we created and live in. And so yet we have to know what those knowledge and skills are, but take them to the people that need them. And the third thing in the theory of planned behavior is social norms. So I love the curve of disruptive innovation, because it always makes me think that usually we launch things in health and we try to get everybody, and everybody has to come to this same training. But you can use the disruptive curve of innovation to start with those early adopters, get them doing the work that I know you're already doing, do that work and publicize it as widely as you can. Let everybody know about it. And what you'll find is those slightly later adopters will be watching and saying, oh my heavens, have you seen what they're doing? Have you seen how we're talking about it in our institutions? Have you seen the outcomes? You make that, and then you can move up that disruptive innovation curve to even later and later adopters. But if we don't address with the social norms, you can use those people, your early adopters, as your social norms. So now you've got value, now you've got the skills to be able to do it, and now you have social norms that are showcasing you this really, really works, and you can see those outcomes. And that in itself is but do it in those, I really think, to champion, but we don't celebrate enough the successes of those champions. We kind of got to make the others think they want a part of what's going on here.
Okay, we have one
Yes.
one question.
Yeah. If I may add, this is a really great question which you asked. Integrating IPE into quality improvement initiatives is really important, because quality improvement cannot be successful without having different professions on board. And it will be a great, if you are a leader on these quality improvement initiatives, to integrate the IPE competences within the quality and team to enhance it further. Yeah.
All right, thank you very much. We have one more question, if someone wants to ask.
Go on, Doctor.
Can I go?
Yes, yes.
Doctor, you want to go first? Or? Okay. Well, thank you for an exciting, really, panel discussion. My question can be answered by any of the panels, but more directed to Dr. Adel. You know, in health sciences, we started with course-based curriculum, competency-based curriculum, and now entrustable professional activities. Now you're talking about a digital-based curriculum. We have not really done well with the attitude with the last three. We always talked about knowledge and skills. And interesting, when you asked us to reflect, you asked about the digital health in terms of knowledge and skills. So how do you feel really we can do a good job with digital health and attitude? And it can be also by Barb, and certainly, I love the passion that was done with your center. So maybe, you know, how did you change the attitude of people, I guess, to get such a successful center?
For me to go?
So I think if you look last 50 years, how the different professions have developed and they matured. I think yesterday we had an excellent example from Jordan saying that how things went up on the nursing side. We will have this tussle all the time that we are having new things and we want to interject it into the curriculum. We have 26 medical schools in UK. So I went to convince the deans of the 26 medical schools that you need to have the digital health competencies in your curriculum. And they gave me exactly the same what you have pointed out, that, okay, there are two ways to handle it. You tell us that what is the core and what are the specialists, and then we will decide we need to go by knowledge-based, competency-based and this way. Or we can leave it optional, and then the students can think that how best they can incorporate it in their curriculum. So I think it is horses for courses depending on which health system you are in. And I feel that if you are in a very matured educational system, which have got better maturity on the knowledge-based, competency-based, and attitude-based, then you need to plug these things accordingly. But one thing is for sure, which I think I am not hesitant to say, that we cannot shy away from this. We cannot say that the things are not ready and we need to wait and when things will get matured. My biggest concern is when we compare our health industry, if I use the word, with other industries, they are far ahead of utilizing the data and digital to improve the outcomes, whatever their outcomes are. And when we look at our side, we are not doing that very effectively. And I think the barriers could be that it is not part of the curriculum. Barriers could be there's no technology available. Barriers could be there's not enough funding available. And my answer is become the role model. So one of the way is that one organization become the role model for success for themselves. I had a wonderful conversation during this meeting with colleagues sitting in the bus and here and there, that they could be the trailblazers. So you can say that my organization could be the trailblazer for one thing, and then they can go ahead, other people can follow.
Okay,
Thank you.
thank you.
Dr. Nasser,
Dr. Adil.
trying to answer.
I think due to the time constraints,
Really? Okay.
I would like to thank, sorry, Doctor.
Oh, no problem.
If you want to add one more minute, so go ahead, Doctor.
Okay, all right.
Sorry.
Digital pedagogy, as if you may call it, right, is something that we cannot shy away. Most of the universities in the world are going to embrace this. Now, trying to link this with what I presented in terms of how do we actually bring in those change. If you look at change that has been embraced by people, they need to have that ownership. So if you have to create this ownership, again, this is what we said, deficit-based approaches may not be the right thing to do. We have been doing deficiency and deficit-based approaches in the past, trying to identify what are the problems and trying to fix it. But I always feel that even for digital pedagogy to come and to be embraced by the academia, it is always strength-based approaches that are going to be. As he rightly said, show them what really is in due for them, having role models, give them those enough examples of how they excel. So I feel that if that ownership is created, change will fall within. Thank you.
Thank you, Dr. Ali. As we conclude this talk, I wish we continue this thought-provoking talks. I would like at the end to thank our distinguished speakers for sharing their experiences. Also, I would like to thank my co-moderators for helping me with this panel. Thank you all for your enriching discussion, and see you, inshallah, in the next session. Thank you.
Excuse me, there's some housekeeping issues we would like to mention. Now we will have a break for 30 minutes. And I would like to ask the topic experts. You see the groups. In the groups, we sent you where you're going to be waiting for the audience to come to you in the room, which is when you go out, you go to the right, and it's a VIP room, okay? The topic experts will be there. So you can grab your tea, coffee, and biscuits, and you go there, please. Waiting for the participants to ask you about the topic they are interested to ask about. And please be strict on time, because we have another session before lunchtime, similar to this session. Thank you so much.
عليكم ورحمة الله وبركاته everyone وأسعد الله صباحكم بكل الخير. السلام عليكم ورحمة الله وبركاته everyone وأسعد
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله تعالى وبركاته. حياكم الله جميعا في الثاني البرامج في هذا اليوم الثاني من هذا المؤتمر المتميز. ولدينا الحقيقة موضوعات جدا مهمة في هذا السيشن، ويشاركني الزملاء الدكتور عبد الله والدكتور عبد العزيز في إدارة هذا الفقرة. وسنبدأ بأول المشاركين معنا، ويسعدني it's my pleasure to introduce Professor Omnia Allam. Omnia Allam is a pediatrician by profession, and she had a master in computer sciences, and she is an educationalist. She is the lead for the postgraduate in medical education in Buckingham in UK. She unfortunately was unable to attend with us, but she has sent the recorded lecture. So we will have the recorded lecture for her just now. And I'm sure we will benefit a lot from her experience. Particularly, she is interested in use of AI in medical education. So please, can you post the first lecture of Professor Omnia Allam? Can you play the video?
السلام عليكم ورحمة الله وبركاته everyone، وأسعد الله صباحكم بكل الخير. I am Omnia Allam. In the next 20 minutes, I will take you on a short journey. This is the journey of interprofessional healthcare education. We will look at what holds interprofessional healthcare education together and what it challenges. In this presentation, I will share with you the AAA's framework: adopt, adapt, and assess. This is my simple guide to think about how we can use AI responsibly in our day-to-day work as interprofessional healthcare educators. Before we progress with the presentation, we need to make an agreement. IPE, interprofessional education, is, always has been, and must remain human. At its core, everything we do begins with the human connection. This human connection is the invisible architecture of every effective team. It is the glue that holds us together. This human core is the essence that we all educators must protect. The presentation today is not about AI, it's about us, the educators. At the end of the day, AI is a tool in our hand. Like any other tool, it can only serve its purpose when it amplifies what is already human. Having said that, I am fully aware that this human model, as powerful as it is coming under extraordinary pressure. We cannot keep doing it all by ourselves. It's not sustainable. This is happening everywhere in the East as much as in the West. We are all facing pretty much the same kind of challenges. For example, we are all facing a huge challenge with the healthcare workforce. Simply, a global shortage of health professionals. The WHO warns us that by 2030, we could be short of more than 10 million health workers. This shortage, of course, will definitely affect both the clinical care and the education. Additionally, the complexity of care keeps rising. People are living longer, often with several long-term conditions. The issue here is not lack of information or lack of technology. Information is there, however, we fail to connect it. Digital systems and technology multiply all the time, yet our communication becomes more and more fragmented. In addition to that, we continue to face more and more gaps, whether this is geographical, language, gender, or digital literacy. These differences still shape who learns, who teaches, and who get left behind. Technology was meant to be bridging these gaps. However, unfortunately, it seems that technology actually widens these gaps. And finally, what I call education innovation fatigue. We face new technology every day, faster than we can truly evaluate or even get used to. Platforms keep changing, we cannot keep up. Many educators feel overwhelmed rather than empowered by technology. Historically, throughout the history of interprofessional healthcare education, we've always used tools to help us teach and learn better. For example, in the 1960s, we started using the standardized patient to bring realism into teaching and assessment, and then in the 70s, the OSCE emerged structured and objectives to help focusing more on the teamwork as well as the individual skills. And then in the 80s, we moved to simulation and later virtual patient, creating safe spaces where different professions could practice together as multidisciplinary teams before they faced real patients. Each of these tools was at the time a new tool, a new technology, yet we adopted them. We adapted them and integrated them simply because they helped us in our day-to-day work. In the same way, AI is the next tool on that journey. When and if used appropriately and ethically, it can support collaboration, improve feedback, and free time for what matters most for us, learning with and from one another. So having recognized the main challenges we face, accepting that we've always used tools to help us and support our teaching, we can now see AI as the tool of today. In the next few slides, I will share with you how AI is being used successfully to address the 4 challenges we identified: workforce capacity, rising complexity of care, equity and access gap, as well as education innovation fatigue. Starting with the staff shortage, here in the UK, the NHS has piloted and now using an AI tool to help educators who lead multidisciplinary teams reflect after teaching or clinical sessions. Usually, after a session, everyone writes short reflection. Reading and analyzing these reflections takes a lot of time and energy from the educator. This new reflective tool does the first part of the work. It reads the reflection, anonymously looks for common themes and patterns, and then gives a short summary. This helps educators save time and focus their energy on the deeper part of the reflection and the discussion with the team. In Sweden as well, they invented the AI Tutor Project. This project supports students during the interprofessional case discussion. The AI listens to the conversations and offers more real-time prompts, for example, short questions or gentle reminders to help the team reflect, stay focused, and learn from one another. It doesn't replace the supervisor or the tutor. It does help them by reducing the pressure as it takes care of the routine part, freeing more and more time and energy for the human connection and the real teaching moments. Moving on to the next challenge, rising complexity of care. In Canada, they have developed an AI-powered simulation platform. This simulation platform trains interprofessional teams to manage complex patient care. The AI observes how the team responds and gives instant feedback on teamwork, communication, and patient safety. Without the AI tool, this would take hours for a human educator to review. The AI tool saves time, helps educators to handle complex cases more effectively. Also, in the US, at the Mayo Clinic, they have built an AI-enhanced simulation program for interprofessional training. The AI analyzes how the team communicates. It then uses predictive analytics to find possible communication gaps or even points where teamwork could break down. Educators use this insight to give targeted feedback on teamwork and communication, helping teams build stronger collaborative skills. Basically, AI gives us, the educators, a clearer and faster way to see patterns that are very hard to spot in real time. AI is also used successfully to help us make learning more inclusive and accessible. For example, in New Zealand, adaptive AI platforms personalize interprofessional learning, adjusting the pace, context, and even culture to meet the needs of the learners. In Australia, the Digital Bridge project connects remote healthcare teams using AI translation and simulation tools. Both tools allow professionals from different regions and disciplines to learn together, share experience, and build collaboration no matter where they are. Moving on now to the last challenge, I always keep the best for the last. Education, innovation fatigue. Many of us feel tired of new technology. There is always something new, and it becomes very hard to keep. The good news here is some universities show us how AI can actually make things easier for us, the educators, instead of adding extra layer of pressure with the technology. For example, in the Netherlands, they use an AI dashboard. It collects information about teamwork, who speaks, how people communicate, and how they work together. And then the AI shows this in a clear, simple chart format. This helps teachers understand what's happening in group work without feeling lost in the data. It gives us, the educators, more confidence and control when using technology. Additionally, another example, in Singapore, they use an AI educator assistant. After a teaching session, it writes short summaries and suggests reflective questions for the team. This definitely saves time and helps the educators focus on the most important part, the discussion and the learning between people. So, as we've seen, AI is already helping in many ways, saving time, improving feedback, and connecting people across distance and discipline. However, AI is not perfect. It's not magic. If we use it without care, it can do real harm rather than help. It can mislead learners, reproduce bias, or even make our teams more divided rather than more connected. If we take educator capacity as an example, I can help by handling repetitive tasks and freeing our time for mentoring. However, if we rely too much on automated content or feedback, we risk losing our professional judgment and our academic integrity. In team learning, AI can connect the insights across professions and help us see patterns we might miss, as we've seen in the examples worldwide. However, if the system is already biased, for example, if we train our system on one profession perspective only, it can silence others. It can reinforce hierarchy instead of improving teamwork. Inequity and access, the third challenge we identify. As we've seen, AI can open doors for remote learners, for those who work in low resources or even multilingual settings. But, and there is a big but here, if infrastructure or training is limited, the same tools can deepen the digital divide. And finally, in assessment and feedback. As we've seen, AI can give timely, data-driven insights, but if feedback becomes fully automated, we lose the context and the nuance and the humanity that makes feedback meaningful. So the challenge for us is achieving the right balance. To lead, not to be led. I repeat, to lead AI, not to be led by it. To question it, to adapt it, and to hold it accountable to our principles and values, not to change our practice or our values to cope with the AI. That's exactly why I developed the AAA's framework, adopt, adapt, and assess, to help us think critically and consciously before we act. The 3 A's framework, the framework I developed and sharing with you today, adopt, adapt, and assess. This framework offers a clear, practical structure to guide us how we bring AI to our practice as educators thoughtfully, responsibly, effectively, efficiently, ethically, and always with purpose. Let us bring the AAA, the 3 A's framework, to life through a practical example that many of us will recognize. Imagine a teaching hospital in our region designing an interprofessional simulation on sepsis management. The team includes medical, nursing, pharmacy, and respiratory therapy students, all learning to collaborate under pressure, just as they would in real life. The first step is adopt. The educators use AI tools to coordinate schedules across the 4 professions, a task that used to take days of manual effort. Then comes the second A, adapt. We don't use AI content blind. We should refine it to fit our regional clinical pathway and, most importantly, cultural context. And finally, the third A, assess. After the simulation, the students and the educators review AI-generated analytics to see how often each profession contributed, who initiated communication, and where teamwork might be more inclusive. The data visualizations makes the invisible visible for us, showing us patterns of interaction that we can discuss openly in the debriefing. So, the 3 A's framework transforms artificial intelligence from a shiny tool into conscious partner in education. It shows that when AI is used intentionally and ethically, it enhances rather than replaces the human essence of interpretation. And think, in your own institution, where could this framework stop? What would adopt, adapt, assess look like for your teams, your learners, and your patients? As we close, I would like to remind you all, and remind myself, of course, artificial intelligence is not the story. We are. The question has never been whether AI will change education or not. It already has. It already changed our practice. The real question is how we, as interprofessional educators, consciously choose to shape that change. So let us commit to staying human, to adopt technology with wisdom, to adapt it with culture and contextual awareness, and to assess it with integrity and compassion. The future of interprofessional healthcare education will not belong to machine. It will belong to us, educators, human educators. And at that point, I would like to close my presentation and thank you all for listening. Thank you so much.
Many thanks to Professor Allam for very instructive and useful approach to use AI. And I will echo the wisdom statement to lead and not to be led by the AI. Adopt, adapt, and assess the process of utilizing AI into the IPE. Thank you very much, Professor Allam, and she welcomed any communication with her email for the anything related to her presentation. We will post the email at the end of the lectures. Now we turn to my co-moderator, Dr. Abdullah, for introducing the next speaker.
Assalamu alaikum wa rahmatullahi wa barakatuh. Our next speaker is Dr. Iman Al-Labban. She has a background of pharmacy and a master in medical health professional education. She is the director for the Center of Interprofessional Education and Research Practice and Assistant Dean of the Assessment and Evaluation and Director of Student Happiness Center from the College of Pharmacy, Gulf Medical University in Ajman, United Emirates. Please join me to welcome Dr. Iman.
It's working now? It's really a great honor to be with you here in this amazing conference in the second day where we're all talking about interprofessional education, interprofessional collaboration, talking about barriers and challenges that we have been facing regarding IPE, implementing IPE, either during the teaching in educational setting or at the practice side, or there is a great need to do some changes. And there have been having a global consensus on the all of us now are sure by evidence that interprofessional education is a really crucial to graduate a collaborative ready healthcare professionals. Yet, till the moment, and all of us has been hearing and knowing and facing challenges in embedding and building and integrating IPE in our educational curriculum. And I have been thinking while preparing for the conference, should I talk about how we design our curriculum? I've been spending 5 years at Gulf Medical University. We have the amazing facility for interprofessional education, almost 9 healthcare programs in one campus, the clinical setting, our own educational hospital, 2 minutes walking distance where our students are trained there. Physically, there have been no barrier for doing and implementing IPE. We had the leadership support, but still we have been facing a lot of challenges. So I thought, why not to talk about a framework or a question that help us all. If we try to address these 4 steps, we will be able to tackle the challenges, change the rocks or the barriers, and use them to build a bridge to have a longitudinal interprofessional education curriculum. When we know the barriers, we know how to tackle them. We are in Abha, there is the mountains, we build the hospitals among all these rocks. We managed to do this education once we are aware what are the barriers, ready for them, we will have the right tool, the right process to do IPE and longitudinal IPE. So I will be starting with thinking out or organizing what are the different barriers that we are facing in the academia. Starting with pinpointing major types of barrier. First is the program designs. We have different healthcare programs, each of us having their own design, credit hour, competency framework. So this is the first barrier that we need to look and see our programs with a unified lens. The second barrier that we are thinking about is the faculty readiness. Faculty are busy with their teaching styles, curriculum, their own professional curriculum. So this is a barrier, and this is the second thing, how to make all the faculty ready for IPE. Third is the hierarchy and our identity. We have been there. I'm a pharmacist, and I had to think from interprofessional perspective. Leaders, all us as a leader or professions, we have our own identity. And still, this is something that we need to change to think from a perspective or interprofessional perspective. Even the students, all of us have this as a barrier. The second is the assessment. We have our own assessment that we are doing it in all of our courses. So assessment misalignment, or if we do it inconsistency, this will be a barrier for successful implementing of the IPE. Then the clinical reality. We have our own clinical practice in our hospitals, in our clinical setting, and there has been disconnecting of what we have been trying to do in education and what's actually happened in the clinical setting. Everyone is comfortable. We try to do IPE sometimes in non-real or non-clinical relevant scenario that they are non-authentic and doesn't match the practice or non-applicable to the hospital setting. The last thing, which is the resource limitation. When I see a resource here, not only physical resources, but also educational resources. So when we know the limitation, we would be able to be ready and get the needed resources. So the key framework or the reflection from the journey is we want to have a sustainable IPE, or interprofessional education. And this needs to be longitudinal to be able really to make a change and change the behavior and the skills and attitudes for the students and practice. So the first key concept, we don't want IPE as activity, sporadic activity. We need to have a change, a context that IPE, to do the change, we need to make it a progressive longitudinal curriculum. And to do a curriculum, we need biomedical education to follow a model. So we have been, and most of us has been, knowing Tyler model as a rational model for designing competency-based education. So how to apply this model in IPE to get a longitudinal IPE curriculum. So Tyler model has been used for years in competency-based education, and the model asks 4 steps or 4 questions. So let's think and know these questions and reflect together how this can be implemented in IPE. So number 1, we need to define the purpose, identify the objective from our curriculum, the what. The second is what type of experience that we want to have in our curriculum, intentionally chosen to match our purpose. The third is how we will organize this educational experience in a longitudinal curriculum, sequential, tentatively, by informed decision and by theory to help the students progress in developing the IPE competency. Finally, with evaluating the outcome, assessing the outcome, assessing the effectiveness of our curriculum. And I believe all of us are applying this framework in our profession-specific curriculum. So let's reflect or discuss together, can this be applied in IPE? Let's ask the 4 questions or go through the 4-step journey together. Number 1, defining the purpose. And this is the first key step. It's complex to start with IPE without having a clear purpose, and we all agree on that. We need to have graduates who are collaborative ready. How to start with that? First step is to agree or have a consensus on IPE competency framework. Next, we need to think how to integrate this IPE competency framework or our own healthcare profession curriculum. Then the third step is to identify pillars in our curriculum where we start to put stones to build a bridge. نقاط مشتركة, okay, to start our bridging. I will share examples of what I've been doing. So first, consensus on a framework. We started with the EPIC framework, where this will be the starting point for our IPE curriculum. Then we have been moving, and as Dr. Susan presented yesterday, to start to work in building a national competency framework that contextualized to our unique needs in the healthcare system and educational platform in UAE. So step one, choose your framework that match your current need and the educational and clinical setting. Then we need to integrate these in our ongoing healthcare program curriculum. So in United Arab Emirates, the CAA, which is the regulatory body responsible or the governmental body on educational and licensure and accreditation of different universities, has been working hardly, and I believe this is also going in the Saudi Arabia, to have a unified competency framework for different healthcare programs. So we analyze these competency framework and realize that there is a common, by minor change names, competency pillars that are there shared among all the programs that IPE can really explicit or build under these competency that we can tag to our program. First is patient-centered care, teamwork and collaboration, communication, professionalism, and evidence-based practice. IPE can highly, or the EPIC competency can be easily tagged or go under the umbrella of what we already have here. So choosing or trying to tag IPE with the EPIC domain under this umbrella. The second part is thinking or have a look at our curriculum and how they are designed, healthcare programs curricula. If we look, each one look, and university look at our curriculums, there is 4 common pillars. First pillar is the foundation of biomedical sciences courses, where we usually teach this in early years, year 1 and 2. Then the curriculum progress with the second pillar, the green one, which is the clinical sciences pillar, that's specific to each curriculum, where students start to study about patient care in the clinical setting from their own profession perspective. Third pillar, about social and administrative science, such as talking about ethics, healthcare systems from a profession-specific perspective. This is the third pillar, and there is a research and evidence-based courses that goes under this. So we need to have a common ground, check our curriculum, and see the curriculum with the same eyes. These are the pillars. Highlight them in your curriculum plan or table and try to identify these pillars in your courses. Once we all ready and see our curriculums, our own profession curriculum with these perspective, we will be ready to find and pinpoint IPE in longitudinally in these courses. So I see IPE as a pillar that integrated or infused in all these. It's not a standalone. This is what I have been thinking or shared. It's not a standalone pillar. It should be infused properly in all of these opportunities to have a longitudinal IPE. Because when we started to have an additional pillar with their own courses and credit hours, this has been a lot of challenging since each university has their own time, study plan. So we want to infuse, okay, or put a pinpoint for IPE in all these or in a selective pillars in these themes. Next question is, okay, what framework among all these pillars we will talk? A conceptual framework. And this framework has been developed by Professor Hussam Hamdi, Chancellor of the Gulf Medical University, is how we will see the IPE framework. So we know that IPE require collaboration or communications and also interactions between different healthcare providers. And we thought about the framework to have a person-centered cared framework, linking IPE with interprofessional practice in the clinical side. And the model that we use, or the thematic model for the curriculum, is to link it with a clinical systems, like we will talk about cardiovascular, a disease phase, for example, endocrine, women's health, whatever, but we need to link it with a clinical and seeing the patients or talk about the disease phase or the pathophysiology. The second pillar is the socio-cultural model. We want the students and the teaching will be linked with seeing a patient as a human and targeting these interactions. So all the IPE activity will be grounded to clinical and socio-cultural, how to talk, see the patient or the person with a disease, but also don't forget the patient as a human. And start to design all the educational activity linked to these two major concepts. The second thing, IPE should not be taught away from the practice side. So the curriculum design will go longitudinally over the year, mixing or going through education and practice, keeping our eye in the design and the students' experience assessment, moving from both education and practice, having it early in the curriculum and start to progress. The second thought, when we do IPE, it is a competency-based, and Barbara mentioned we need to have it progressive competency, and to have this, the traditional teaching and the teaching styles will not be like a didactic. We want it to be linked to experiential learning, situational learning, and having the theory of community of practice grounded to these principles without forgetting that this is a social aspects or a social theory of interaction, because the students need to learn with, from, and about each other. So they need to interact. So this is a pillar in our selection or defining the purpose. The second step, we define the objective theory, how we want to find it. Think of the educational experience. Where we're going to teach that. So we started to think of early, we have the option to have a didactic learning, such as lectures, for example, where it will be suitable at the same foundation, early year, discussing the roles and responsibilities of different healthcare professions. And as you see, this can be easily tagged or linked to social and administrative science courses in early years, such as communication course, ethics, introductory. Inject IPE early, where the students need to know about their roles and responsibilities, and the role of responsibilities of different healthcare providers. At this early stage, the students themselves in all the programs are still doesn't know or doesn't have the knowledge for the clinical experience to engage in something related to clinical or patient-centered care. So it is very good as a starting point to start on this, and then once they start to move in the next years, to go through the simulation-based care in a session, IPE session, in the clinical simulation courses. Then clinical placement will be the third option or the pillar for our curriculum. The experience can start to be organized longitudinally, thinking of having the model for exposure, immersion, practice integration, where the learning experience and teaching style will go in gradual years to match this. And assessment method should go gradually reflecting this, such as starting with reflections, portfolio. Then when we move to the simulation, we move to team-based simulations, team OSCE, or even rating by different team, while in the clinic, the setting or the assessment will be about work-based assessment. What works best and can go through this is the e-portfolio, or to have the students reflecting during this journey to have longitudinal IPE. Regarding governance, we started to have IPE committee, and again, the committee is divided to members who works and lead these three stages, where they together work on co-creating the learning, identifying participants, train facilitator, scheduling together, and deliver, assess the team, and share the scores with everyone in each program. Regarding evaluating the outcome, same framework we use in evaluation, but once I have this structure, you would be able to start evaluating the learner from the different pinpoint throughout the journey in these different assignments or courses. Then we can also move to have the programmatic evaluation as one of the things we all do in our program, that we have exit exam maybe, or readiness for practice exam at the end, inject module or a test or part of IPA there to have the capstone or their final readiness. We ask the graduate during exiting the program about their PLO satisfaction. We know that IPE is tagged to the PLO, which measure collaboration, so you can have this as a point of programmatic evaluation. And also, we sent the employer evaluation feedback about their satisfaction with their graduates, which it is tagged to a collaboration competency and how they see them. So this can be
Dr.
the final
Iman,
framework that we have.
I'm very
about
sorry to interrupt you.
IPE. So my final message that it's a way of thinking, it's a final shift of our mind with a careful curriculum design based on scientific evidence and informed decision, we can move from having or reducing the barrier to opportunity for building bridges. And finally, I would like to thank all the GMU faculty and leadership that I have been blessed to work with them during these 5 years. Professor Hussam Hamdi, who have been mentoring, supporting throughout the journey, the ANAC, and of course, King Khalid University for their hosting the conference. Thank you very much for your time, and thank you.
Thank you so much, Dr. Iman. If the time was not limited, we would love to listen more and more to your presentation. Thank you for the great presentation. I will give the mic now to my...
Assalamu alaikum wa rahmatullahi wa barakatuh. It is my pleasure to introduce the next speaker, Prof. Muhammad Al-Mansour. Prof. Muhammad Al-Mansour is a professor in medical education and a consultant of family and community medicine, Department of Family Medicine, King Saud University. Dr. Muhammad Al-Mansour, he earned several qualifications, including Certificate Leadership in Health Professional Education, Fellowship of Medical Education, Certificate of Keystone Health Simulation Program, Diploma in Total Quality Management, Canada Global Center, and as well as his main specialty, which is the Saudi Board Family Medicine and Out of Board in Family Medicine. Please all welcome Dr. Prof. Muhammad Al-Mansour.
Thank you so much, Dr. Nasser. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. الحقيقة أني جدا سعيد باللجنة العلمية للمؤتمر وأيضا للتحدث أمامكم. It's really a mixed feelings to be back in King Khalid University, my home.
I graduated from here a long time ago.
But it is really a pleasure to see this advancement in the university. So today, inshallah, I will be quick because I've been challenged to be the last presentation before the lunch. So also I've been challenged that most of the presentation that before me, they said most of the things that related to IPE integration in the curriculum and so on. But let me take you in this quick presentation to talk about the second part of the slogan of this conference, which is identifying the gap and measuring the impact. So I will try to focus more on measuring the impact of IPE-CP on our healthcare system. Okay, so our outline will... sorry. Oops. Okay. So we'll go through the quick definition. I don't need to go through it. It's been already explained most of those 2 days sessions. I will talk about clinical and humanistic outcomes, and I will talk about some examples from the acute care, economic outcomes, and how about the interprofessional education impact on healthcare providers or healthcare learners. Then the most important thing, I will talk about what is the limitations and the future directions in measuring the impact, which is, I think, the major thing that we need to get out of this conference with in this particular focus. And also I will talk about, at the end of the day, about the conclusion and the recommendation. So quickly, we'll go through the definition. I think you are now saturated with this definition, IPE-CP. The most important thing is the aim. Let's keep our eyes on the ultimate goal of all of this, which is the improvement of the healthcare outcomes. And in this presentation, I will go through our work in the book that's been directed by Professor Al-Na'mi. He gave me a great pleasure to co-write a chapter about impact of IPECP on the healthcare outcomes with Dr. Osama Shagran, and I hope he's with us here, but unfortunately he's busy, and I'm really acknowledging his work. So what we did, we went through the literature, we try to make the outcomes in a sort of classification or framework to make it easy for anyone want to explore the outcome of the IPECP, how to do it. So simply, we found in the literature, many literature, talking about IPCP and IPE. So linking IPCP to the outcome and linking IPE to the outcome. So what sort of outcome that we found in the literature? We found two kinds of literature. Two kinds of the outcome. Individual outcomes and organizational, or let's say system outcomes. So I will not go all over those outcomes. It's there in the chapter, but the most important thing is that some outcomes that are overlapped between two, and the most important thing that we have a gap in measuring the outcome between the IPE and IPCP in a lot of literature. So they just keep concentrating on one wing of this approach. So, for example, we are talking about patient safety, the well-known that you already heard about it, patient safety, communication. We are talking about some clinical measures and like for example, glycemic control, blood pressure control, quality of life also, the value-based care in organizational part, the patient satisfaction, using of resources, cost, and I will come to the cost in a separate slide. So next one, this is from IPECP, IPC from the state. I think Barbara has presented in her presentation, and also Dr. Iman just mentioned about it. So it's well-known framework in the state. But what I like about this framework is that we need always to look about IPCP implementation from, let's say, a bird view. So when we talk about educational system and professional system, and how can these two systems interact with each other while we are approaching the IPECP. So this is really important in our outcome, because sometimes we are stuck in one of those systems and measuring the outcomes of one of those systems and ignoring the other. So it is like what Dr. Iman presented. It is bi-directional interaction. It's not one direction. So it's not a linear going from the educational to the healthcare. It is all the way between each other. So it is important to think about it in this, let's say, horizon. And what is the fuel for measuring the impact is research. And I think it's been mentioned in the previous sessions many times, but the research that focusing on the impact is really lagging in many literature, and I will come to this. But please keep this in your mind while you are planning any IPE activity or program. You need to look to the big picture and then dig deep to your work. So I will go through some clinical examples, or clinical outcome examples. It's just a few of them, and the rest I will leave it for you in the references that you can get it from there. So for example, improving the IPCP, improving the chronic diseases, specifically diabetes and hypertension management, reducing the blood pressure readings, improving the hemoglobin A1C, and a recent study after I just went through the literature again after our chapter being published to see what's going on after that period, and I find also some of the studies talking about chronic diseases and implementation of IPCP, IPECP on them, in more team components, better blood pressure outcome, for example, and a recent study also talking about multi-morbidity care and how can IPCP improve that one. So the problem in these, there is a mixed result across the studies with different definition of the outcomes. I'm talking about clinical outcomes. And this makes things somehow difficult. I think Barbara, she tapped on this part this morning, that measuring the outcome is not easy in a complex situation like IPECP, but make sure that when you are planning any activity to put the outcome first, then go backward, like what we are doing in education system with outcome-based education, for example. So another example from the acute care, wonderful systematic review and meta-analysis about the delirious patient and how can IPECP improve this, and they found 7 out of 10 studies showing that it was really effective, reducing the incidence, severity, and duration, and length of stay in hospital, which is counted as a systematic system or as organizational KPIs for many health institutions, was really improved. Recent study talking about the teamwork in the ER, and it's really amazing how having interprofessional team in the how to have interprofessional team in the ER, improving the trauma approach, which is I think most of our big hospitals, we have a trauma team led by a trauma leader and involved many professions in one team. Then I like what Dr. Allam said about being human. Let's stick to our essence, being human, with this advancement in technology and approaches, which is really important. And we found it also as one of the outcomes of applying such approach, which is IPECP. So some studies reporting that the IPCP improves the quality of life of patients, their coping strategy, their satisfaction, and their trust in the health system, which is really important. So to gain the trust of our population, not only our patients, to our population and community, is really important for us as a healthcare system. So this could be in regard of certain diseases, or it could be in general about the approach of health care practice. Important talk of everyone today is economic, cost saving, cost effectiveness. How could we make it with the limited resources? So again, this is another horizon for impact and outcomes. And really interesting that there are some studies talking about the cost saving of IPCP. Some of them talking about certain diseases, like for example, this study talking about decreasing hemoglobin A1C by 1% by applying IPCP was reducing the cost by $40 per patient. And also an interesting study talking about student-led clinic reducing the ER visit for diabetic patient by 75%, which is converted to a cost currency, let's say, it's a huge saving. Later on, ICU stewardship, decreasing the antibiotic cost by having IPECP team handling the antibiotic use is really effective from the cost perspective. And recent study also talking about the split share between physician-pharmacist model lead to decrease the direct medical cost of the consultation. So, is it enough? No, I think this is a huge area for research. So please, when you plan any IPECP intervention, put the cost one of your leave it till the end and as a secondary objective. What about the IPE in particular? So we are educators, we are talking about education most of the time. Is that going to reflect it on healthcare at the end of the day? Some studies, they try to link it from the education directly to the outcome of the healthcare. But most of the studies lying on the learner outcomes, like improving skills, collaboration attitude, teamwork attitude, satisfaction of the learners, and so on. So recent study showing that high collaboration and knowledge and knowing about collaborative practice is more in those learners, which is well known. But I want to leave you with this nice figure that talking about the continuum. Please, when we are talking about IPE, we are not talking about one level or certain course. We are talking about the continuum. How can we take this from the fundamental, very basic years till the ongoing professional people like you guys while you are doing your practice? So all of this continuum is a medium for IPE and a medium for measuring the impact. So while we are doing this, let's keep the impact measurement in our mind. And here is some interesting outcomes, like for example, Kirkpatrick's. And by the way, most of the studies that we found, it lies in the reaction, some in the attitude, perception, less studies going to the top of the Kirkpatrick's model to reach to the practice and doing. So what about linking this to healthcare system outcome? In the left, it's really important. When you are doing this, keep the healthcare system outcome in your mind and put it as a goal. I think this has been seen by Dr. Iman, IPC core competencies. Just that I want to say out of this slide that it's keep evolving, they keep changing it and updating it, so it's a dynamic, not a static, so keep up with it. Now I want please to concentrate on this. What is the limitation of the studying the outcome? We have a lot of limitations in the literature, like for example, the studies showing a high heterogeneity and many biases because, as I said in the beginning, the taxonomy is different. The people talking about IPE differently has also been introduced during this conference. The people define IPE differently, then also they define the outcome differently. So make sure that when you are designing a study to clarify what is the IPECP approach and what is the outcome that you are seeking for. If you evaluate the direct patient outcomes, most of them, they just stop at the reaction of the participant. And they need to, as I said, to define, unify the definition and taxonomy, require a long term, this is very important. To have this continuum measured, you need a longitudinal measurement, longitudinal studies. You need high impact, robust study, like for example, RCTs and cohort and prospective studies, that it takes the time for the learners to go through the learning system and getting to the practice system and see the impact on the population and community. This is very important and crucial, and it is limited in the literature, by the way, including morbidity and mortality outcomes, including the other outcomes like the cost that I said, and expand the evaluation for all the levels, from the learning levels till the organization level. At the end, IPCP is proven to be effective in different categories: humanistic, economic, clinical outcomes. There are a lot of studies in the literature, but we need to know that we need to improve the quality. We need, for those measurements, we need to keep it as embedded in the system. And I put it as one of the recommendation for the conference, that we need this to be part of the metrics of the health system. Otherwise, you will not measure it. So if it's not in the mandate and the KPIs of the system, you will not recognize it at all. And I think we need to scale up with implementation, with a strong evaluation in each different section of our implementation. These are the references. This is the book that I'm honored to be part of it, and I'm happy to share the presentation with you, and thank you.
Thank you, Prof. Muhammad, for your wonderful presentation. And I would like to invite Dr. Iman to join us for the panel discussion. And I think for the short...
Professor Allam is also with us, so you can address the question for her too. Any questions?
السلام عليكم ورحمة الله وبركاته. My question to Prof. Muhammad, it was really looking for the issue from the other end of the tunnel, and I think this is what we are aiming for. I have an issue about the IPE in terms of when shall we start to maximize the effect, and what percentage of the curriculum should adopt the IPE in that curriculum. And the third one is how can we neutralize the co-founders, which is the disruptive workplace, the graduation, the work after graduation, people who've been through the entire system, they will work in different organization, and how that will impact the measurement of the impact. I think this complexity is are common in the problem probably you have.
Thank you, Dr. Khalid. Yeah, it's a complex question, by the way. I think, yes, it is the challenge. And yesterday we've been in a nice workshop with Professor Siraj, and we've been debating about some sort of this question, when to start it. In the literature, let me tell you from just a quick overview in the literature, that there is a controversy. Some people, they said that it will be more effective if you start later toward the practice, toward the profession. For example, post-grad and in professional education. Other people, like, for example, Dr. Iman today talk about, let's go back to the roots of this health care provider factory, let's say, from the beginning. So I think to have demarcation is hard with a complex and different curriculum, different strategy for each curriculum, different vision. But at the end of the day, as I think, I like the Barbara quote today, don't keep it aside and voluntarily and optional, and then you will never find it in your system. How to implement it, it depends on your setting. Then the second part of your question, which is really my concern, how to measure the impact all over this? How to measure that if I'm putting 30% of my curriculum IPE, is that gonna benefit or not? This is another journey, because it should go, as we said, with the evaluation hand in hand with your curriculum implementation. So while you are designing the curriculum, implementing the curriculum, and evaluating the outcomes, it should be in your outcome evaluation. Otherwise, you will not recognize it, because the student, they learn your core curriculum with different modalities, and you will not recognize what is the impact of IPE directly to the outcome of the education and outcome of the practice. And by the way, it is the challenging point for the researcher. Thank you.
Thank you. Any questions or comment?
My question to the panel, first of all, thank you. It was great talks today. How can we have a sustainable impact in the field? My question, are we involving enough our colleagues in the field in developing the longitudinal curriculum or the themes? Because as academicians, we are doing a lot of efforts. If there's no sustainable impact in the field, then a lot of these efforts will be, I would not say waste of time, but I mean, will not benefit a lot from it.
I think we should work on both perspectives. And this is one of the things that we are having today in the conference, is having academia, regulators, and clinicians working together, bringing this. We cannot work in silo. It's a healthcare system. The academia and the practice and the governments are working together for better health for our patients. So we should collaborate. It's a consensus that we need to work on the multiple directions to have an impact. What I see from I have been doing that we are working in silo. I have been working with clinicians, companies, doctors, hearing them, having issue out talking about the need to have transdisciplinary team and doing this in their hospital setting, while educators are talking about the same way, but we are not communicating together. So start, champion, let's bring a bridge, discuss together like we are doing here today, and have a common ground. What you are facing in the clinical is we are helping you to get your team who will work with you and help you to solve this clinical problem and enhance the outcome. So it should be both ways.
Thank you, Doctor. I can just comment quickly on this. I think we have a good example presented yesterday by Dr. Ala and Dr. Adil. He's with us today, and it's really, it's representing that the practice, Dr. Adil coming from the practice side and Dr. Ala from the university or the academic side, and they are doing a great job in keeping the momentum of IPECP in Qatar, for example. I think what we are really need to focus in Saudi Arabia, for example, in our context, is to make sure that all of the key players in our healthcare system, they are on board. I agree with you. Sometimes we are just talking to ourselves as an academician. And when you go to the practice, people, they don't know what do you mean by IPE. So I think this is a crucial point. We need to tackle it while we are putting our steps in the IPECP in the kingdom. And I'm sure that people, if they understand the impact of it on the healthcare system, they will be happy to participate because we are sharing the same goal. Thank you.
Thank you very much. Excellent presentations, Dr. Alam, Dr. Iman, Dr. Muhammad. Really enjoyed it. Going through the from implementations to really impact. One comment and one question. The comment is this impact, the patients at the end of the day, they're not going to look at the IPE. They are going to look at their health, whether there is an improvement in their health, which reflected on this teamwork and improving actually the health. So it takes time, and it takes a lot of analysis of what even Dr. Muhammad actually very nicely said about the examples of diabetes and an outcome. If we see ultimately that there is a improvement of the control and improvement of the complications, this is really an impact. My question is to Dr. Alam about the wisdom of now we are facing with with the students, with a very huge, what I would say, a coming of the AI and utilizing this in their assignment, their answers, and it's a very difficult to go and stop this and try to educate them to lead this tool rather than to be led by this tool. So yes, integrating actually AI, teaching them, and is there any strategies that our consensus in terms of utilizing or implementing actually this educations towards our students who are really ahead of us sometimes in utilizing actually AI, Dr. Alam?
Yes, Professor Alam, the question is about the current utilization of the student to the AI sometimes may become unethical. So he's asking, is there any strategies to improve this and tackle this problem? Please go ahead.
Can you all?
Yes, go ahead. We can hear you.
Can someone please repeat the question for me because I didn't manage to hear it? Can someone repeat the question for me, please? Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. If you can hear me, can someone repeat the question for me, please? Because I didn't manage to hear you. Okay, I can't hear the question. Can someone even write it in the chat box for me or repeat the question for me, please? I didn't manage to hear the question. I'm sorry. Okay, can you, okay. Okay, for the ethical use of AI, I believe this is the question. So basically, pretty much every university and every institute has guidelines for ethical use. And I insist, this is the most important part. I think basically the clue for us is to be transparent about what we do and transparent with our students. So hiding the fact we use AI, I use AI, I use it in my profession on a daily basis, and I'm very clear and I'm very transparent with the student about it. So I tell them I'm using AI and this is how I use AI and this part of my work I've used AI for, and I encourage them exactly in the same manner to tell me how they use AI. So I think the key and the way forward is just to be very transparent and be open and clear. So for example, I say to my students all the time, I use AI for admin purpose, for administrative purpose, so they can actually focus on the student support and other parts of the job that needs human input and human interaction. If this is clear. Thank you. Thank you.
I think it is time to close this session. Many thanks to our great presenter today, Professor Allam, Dr. Iman, and Professor Al-Mansour. And also I would like to thank my co-moderator, Dr. Abdullah and Dr. Abdulaziz. Thank you very much. And we'll see you at 1 o'clock after the prayer and lunch, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
بسم الله بسم الله كويس.
دكتور هاني.
ودية بين رجال أعمال ورواد أعمال. كان نقاش على
بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وموالاه ثم أما بعد. Now we are going to the next session. The next session is the student activity debriefs. We are going to present a short video And after this video, inshallah, we are going to give you opportunity to participate in Kahoot quiz game. And after that, we will take question by question. We will discuss why everyone has chosen that particular answer. So we will start presenting the video right now. And after each question, Prof. Mahmoud Adil, who is participating with me in this session, we will make his comments and try to correct some issues. Thank you.
Mr. Stra, we went for bit 7 IV fluid, some CBC and X-ray. I have phone call.
الو
الو استاذ سعد.
اهلا.
مع حضرتك اسره من الطوارئ، عندنا مريض اسمه خالد عايزين نطلب له اكس راي.
But is it urgent?
No, not urgent.
Okay, thanks. الو ايوه خلاص خلص الاكس راي الحين تقدرون تشوفونه.
اوكي ثانك يو.
اهلا.
الاكس راي بتاع خالد ظهرت.
What's your findings?
مش عارفه، ممكن حضرتك تبص على الرقم.
اوكي طيب. يا دكتور بالنسبه لحاله الوالد ان شاء الله شفنا الفحوصات والنتائج ويحتاج تامين. يعطيك العافيه. السلام عليكم مستر صلاح. البيشنت بالنمبر 7 ادمت من برتشيس. انا لازم امشي.
السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله.
كيف الحال يا دكتور؟ حولوا لنا كيس يا دكتور. The patient has a deep wound reaching the calcaneus with osteomyelitis.
طيب أنت شيكت على البيشنت ستيبل ولا لا؟
اي الفايتلز نورمال.
تمام نحوله للأورثوبيديك ما هو تبع.
خلاص بنحول اورثوبيدكس.
المريض هذا بعد ما يسوي الأشعة عندي راح نسوي له إن شاء الله ميوتيشن يعني.
السلام عليكم.
السلام.
كيف حالك يا عم؟ عساك طيب. احنا طلعنا على أشعة وتبين أن لازم نسوي بتر من تحت الركبة. تمام؟ والحين راح أعطيكم وقتكم، أنا بروح أكمل إجراءات وأخلص إن شاء الله.
طبعا القرار هذا جاء بناء على تناقشنا في الحاله والدكاتره يعني اعرف مصلحتكم والقرار ما جاء عبث والقرار هذا افضل قرار بالنسبه لك.
لا لازم تحطون وقت يا دكتور، لازم تعطون ابوي وقت ولازم نفكر في الموضوع.
ما في مشكله، فكر في الموضوع اعطونا خبر.
الو.
Good evening, Dr. Khalid.
Good evening.
I have got a 78 years old diabetic male with an infected right foot, wound extending to the heel bone, look like osteomyelitis, no palpable distal pulses on the right, but the foot is worn proximally. I am considering below the knee amputations and wanted your vascular opinion.
Mm-hmm. All right, Dr. Amr. Thank you for calling. Just to confirm, you've checked pulses on both sides, right?
Yes, doctor. Left side pulses are palpable, normal capital, right side non-palpable.
Okay, good. Before I proceed with any intervention, I'd like a Doppler ultrasound done on both lower limbs. Ask the team to check anterior tibial, posterior tibial, and peroneal arteries, and note whether the signals are triphasic or monophasic or even absent. If there is no flow, call me immediately. I'll come in and assist the patient personally for a possible revascularization before any amputation.
Understood, Dr. Khalil. I will request the Doppler right away and update you once it is done.
Perfect. Just document the findings clearly in the chart and note the time of assessment. Once he is admitted, I'll review him formally. So thank you, Dr.
Thank you, Dr. Khalil. I will do. Thank you.
شكرا دكتور فارس. هذه الانورسمنت وهذه كل الحالات اللي جتنا امس. اي شيء تحتاج او شيء تواصل. يعطيك العافيه. انا لازم امشي. الله يعطيك العافيه.
هذا بت 7 ليه ما في اي دوكيومنتيشن؟ غريبه. رجال ملبس والله. خليني اشوف لي قصه مع دكتور صالح. السلام عليكم.
السلام.
والله ما هو معقول يا دكتور صالح.
خير يا دكتور.
بت 7 ما فيها اي شيء.
طيب اهدى تفضل نشوف شيء. خير عسى خير ان شاء الله.
يا اخي والله ما هو اللي يسوون.
ايش المشكله؟
يا اخي تخيل اجي استلم الشفت الاقي مريض من هو من 12 ساعه ولا سوى له اي شيء. ما في اي شيء.
اول مره تصير؟
لا اكثر من مره صارت. نفس
طيب.
الشيء ما في اي دوكيومنتيشن في المساله.
طيب لا
ايش
ان شاء
اسوي؟
الله ما يصير خاطرك الا طيب. نجتمع برؤساء الاقسام وبنشوف فين الخلل وبنحله باذن الله تعالى.
خلاص اللي تشوفه يا دكتور.
الله يحفظك. لا
الله يجزاك.
Okay, now after watching this lovely video made by the student, now we will ask everybody to participate in the Kahoot. Yes, in the Kahoot quiz. So we will ask people, the organizer now, to show the QR code and make your phone ready to scan the QR code and participate. Okay, everybody ready now? Can we start? Okay. If you participate, no.
Yesterday, he was showing it to the moderator. He was showing it to moderator.
The one.
The one who came here.
Okay. Was the student?
Yeah, this one.
Man, are you around? Can you come here, please?
So for our first question, what element of effective communication was missing in this scenario? 53% chose empathy, while 13% chose clarity, 33% choose timelessness.
Now, we want to ask the students, starting from the audience, starting from a student, why do you think this distractor number one? Yes.
Why did you choose that answer? Whatever your answer was, tell us, why did you choose it?
We need a microphone.
So, for the question that was presented, my answer was timeliness, even though it was not the top answer. I would argue that the X-ray for the patient that was ordered was delayed, even though his case was urgent. Okay, and you can see that him after several hours, he didn't know about anything about his situation until his son came up and asked the doctor. So, for the same reason that he wasn't told, I understand why empathy would be a correct answer to this situation. However, I think timeliness was something that is really essential in his case, and the delay may affect the outcome of his health condition.
Maybe someone who put empathy. Why you chose empathy, not timeliness? Because you have to make one choice. You can't make three. Who put empathy?
For me, there was no clarification of the condition or explanation of the reason for the amputation. That's all.
Okay. So let's go
to the staff. Or
Assalamu alaikum. Iman Shroub, Assistant Professor of Clinical Pharmacy. So clearly what's missing here is clarity and poor documentation, or actually lack of documentation. This is number one. After that, yes, there was missing important part of communication, which is the patient. But the main problem is clarity or lack of documentation. Thank you.
Thank you.
And it was very nice video.
Thank you so much. We will have more. We will have one more comments from this side, or from, any more comments? Okay, I think we'll leave now the room for Dr.
Some reflections. When we say communication, what does it mean? Because the question is about communication. So communication has three elements. There needs to be a message, there needs to be a communicator, and there needs to be a means for communication. So message, communicator, and means for communication, and of course, someone needs to be receiving communication. So we had all those four over there. So people were communicating, and then there are verbal communication and non-verbal communication. If you look at the video, some of them were giving and they were not looking at the person who he or they are talking. So this is the sign of a non-verbal communication. And I think in our professional lives, we need to understand how to interpret non-verbal communication, because we only listen, but we don't observe. And then we also need to remember communication is half of the success. If your corporate life, professional life, your personal life, communication is half of the success. And the remaining half may be on actions. And what I learned over the years, and I'm just setting the context, and then inshallah we'll go to the next question. What I learned over the years, that in our medical school, pharmacy schools, dental schools, or professional schools, we have been trained to interact with patients, and the interaction has two purposes, very clear two purposes. One purpose is that we need to deal with the issue, whether it's a disease or something. And the other purpose is build a relationship. Because we can only manage things, and the first part is your IQ. You know how to treat the patient, is a diabetic, blah, blah, blah. So this is your IQ. Relationship part is your EQ, your emotional intelligence. Your communication comes from emotional intelligence. Unfortunately, most of the places, a lot of emphasis being put, including my medical school, my postgraduate training, my Royal College, on my IQ. How many exams you pass, other things. Less on your emotional intelligence. And this is the reason what we started seeing, that when we go in our practical life, interprofessional collaboration, then our communication is not very strong. The other challenge nowadays coming, that most of the people communicate with a digital means like WhatsApp. So you are losing the skills of the verbal communication, because verbal communication means you need to have the eye contact with the person. Doesn't matter you're having a top leadership meeting with the Minister of Health, or you have a meeting, because that person is very important. Whether a nurse or a doctor, you have the eye contact. In this video, you might see the person was not looking, and this is nonverbal communication. So I think the answer, coming back to the answer, those three things, empathy, timeliness, clarity. And the question was choosing one thing. Under the scenario, it was the timeliness, and all two others were important. Because it was a team communication, the timeliness became important. And of course, there are other things, documentation, and so many other criteria. But no one is wrong. I think the questions we have chosen, no one is right or wrong. Question is, you need to make a judgment call. In this case, the judgment call might be timeliness, clarity, or empathy. But you need to remember that these are the prerequisite for an effective communication. The other thing, if I add, can someone tell me what is the appropriate speed of talking the other person can understand you? If you are speaking in his language, or you are speaking like me in English, right? How many words per minute? Raise of hands. How many words per minute to give a clear message? No. MashaAllah, all of our life we talked. So rather than getting into questions, the appropriate speed is less than 100 words per minute. If you are speaking to audience whose first language is not that what your language is less than 100 words per minute. And if in the same language, it is between 120 to 150 words per minute. And you might see that some under pressure, in our clinical setting, we speak very fast. It included me in my clinical days, running and talking. How we expect the other person. And if you are dealing with a patient who's coming from a different cultural background, language background, you need to be very slow. This is happening in UK. There is a Turkish population, Pakistani population, Indian ethnic minorities are there. And then they started teaching in the medical school that you need to be slow because English is not their first language. Please.
Can we have the microphone? And we have only 1 minute of discussion. And then
just the importance of communication is one of the most important causes of lawsuits, medical lawsuits. In one of the studies in the United States, it's actually communication. The reason is communications. Either the health practitioners did not tell me, it wasn't clear, and they did not tell me what is the consequences or whatever. And these were and I would just say that there is overlapping between clarity and communication. Communications lead to clarity. So if you are clear in your communications, this will lead to clarity and, of course, to effective communications. And I would add also listening is also part of that communication, which is the perception, as you said.
Professor Ahmed, yes. You are on spot. Other questions are coming which will reinforce your point. And just to add one thing about the lawsuit. In UK, General Medical Council deal with poorly performing doctors. I used to be responsible for my region of all the poorly performing healthcare professionals, doctors, nurses, everyone. And when I looked at my database and we wrote a paper, 60% of those healthcare professionals, cases went to their professional bodies because of the communication problem. And there are multiple reasons, but it's a communication problem. Okay, I think with that background, let's go to the next question.
Yes. Now we move to the next question. Make your phones ready to participate.
Using the same code, and for those who don't have the barcode, our question is saying how to constitute a functional interprofessional team based on the availability of staff, based on patient needs, based on specialty, and for example, oncology.
Okay, start answering now. Can you show the QR code again on the screen, please?
Have you got the call? Have you got the call? Yeah. They're still answering.
You want to give a few more seconds or should we announce?
So till now we have about...
Sorry?
I think we have to move forward. We cannot go back, sorry. So now we listen to this call now. Yeah, first, yes.
It's automatic, yeah.
So we have about 18 votes, vast majority based on patient needs with 70%, and the rest for based on availability of staff and based on specialty.
I think now we will take one comment from this side and one comment from the other side because of the time. So why did you choose wherever you've chosen? From this side, from a student?
Okay.
Yes, go ahead.
Regarding the previous scenario, the answer should be based on the patient needs, because as we see, there are a lot of specialties in the scenario, but due to pure communication between the specialist, there was a lack of the decision making. So it was referred to the GS, and then it transferred to the orthopedic surgeon, and the decision was making before he discussed with other surgeon, like a vascular surgeon, and after the decision, he talked to the vascular surgeon. So the decision should be made based on the patient need, and the collaboration should be based on the patient needs. Sometimes in some hospitals or healthcare centers, it's based on the availability. But regarding the scenario was shown, I think it's based on the patient needs.
Thank you. Now we move to the other side. Do you have any comments? No comments? Now I think we will leave the stage for Prof. Mahmoud.
I think you're right. The evidence is very, very clear that we need to be based on patient needs. And I think the emphasis on interprofessional collaboration, because that is the purpose. And once we know what is the need of the patient, then we can find all the relevant people who are going to meet the need. In this case, scenario was accident emergency. And of course, there are dedicated people already attached to accident emergency. You need to call upon them. This is a different scenario. But if this happened in the inpatient, then you need to identify the patient need, even calling the social care worker, because we sometimes go by traditional healthcare professionals. We need to thinking about non-traditional healthcare professionals. We talk about physiotherapists, but there are people in the community who are good, and so these trainers. So thinking about that, you are very right, this is the way we should do it. Okay, let's move to the third question.
Okay, this is the last question.
You can scan the code right now. For those who don't have the code, our question is saying, what key factor caused this adverse situation for the patient? Excess workload of the clinical staff, lack of interprofessional communication training, undermining shared decision making.
Okay, start answer now.
We have about 20 votes with 80% lack of interprofessional communication training.
Okay, now we will have one comment from this side and another one from the other side. We need someone who hasn't participated before from both sides. Yes, go ahead.
My answer was undermining shared, making decisions. And the reason for it is because there was a lack of communication between the staff members. Now, why I put that instead of lack of communication training is because the issue isn't training. It's because of lack of making decisions together. That was my answer. Because at the end, you see the ER doctor being pissed off at the staff for not talking, not working together, not even documenting the case. So that's my answer.
Thank you. That's clear. From this side, do you have any comments? No comments. Okay, now, Dr. Mohammed, you can make your flavor.
Right, like we have been told that there are root causes of issue and there are symptoms of the problem. So in this case, the root cause is the purpose of communication is very clear in interprofessional collaboration, making joint shared decision making. That is the key purpose. And communication is the mean to achieve that purpose. So it means that in this case, that they undermined, I think whoever the gentleman said, he was right. I think on the face value, look like that some of them didn't know how to communicate properly, or it wasn't clear, or it wasn't documented. But the goal is, in the interprofessional collaboration, that we need to be respecting the other profession and thinking clearly that he or she has got a role to play in making a decision. And this is the reason I'm communicating with her or him. And that is the reason this is the key factor in the poor communication and not having effective interprofessional collaboration, because people may undermine the shared decision making. And in the UK policy, they have made it very clear that for evidence-based medicine, evidence-based healthcare, not evidence-based medicine, evidence-based health, that all the health professions need to play a part in the shared decision making.
Thank you so much, Prof. Mohammed Adil, for these comments. And by the end of this session, we hope that everybody enjoy the scenario and also enjoy the discussion regarding the questions have been showed to you. Inshallah, Prof. Mahmoud will be around if someone has any questions, they want to discuss something with him. And Assalamu alaikum wa rahmatullahi wa barakatuh.
طيب بسم الله الرحمن الرحيم. Welcome back everybody after very excellent enriching program over the last let's say 2 days, and I'm very glad to be the moderator for this session with my colleague Dr. Hussein Al-Hussein. And before starting this, I have to acknowledge my bias toward interprofessional education, because my thesis and master's degree in health professional education was about interprofessional education. Second, I'm a surgeon, and you know that the best place of implementing interprofession collaboration is in the operating theater, where we work together with nurses, with RTs, with technicians for treating our patients. So for those who doesn't know me, I'm Hassan Al-Zahrani, an associate professor of surgery and medical education in the College of Medicine, King Khalid University, and currently the president of the Saudi Society for Medical Education. It's also a great pleasure to welcome and introduce my co-moderator in this session, Dr. Hussein Al-Hussein. Dr. Hussein is the Secretary General Deputy for Institutional Affairs, Saudi Commissions for Health Specialties. He served as an Executive Director for Accreditation in the Commission. Dr. Hussein is a radiation oncologist by training. He is neuro-oncology and tactic radiosurgery consultant at King Fahad Medical City in Riyadh. Welcome, Dr. Hussein. So without further ado, because I know some of our speakers, they have flight, it's my pleasure to welcome our first speaker, Dr. Mona Sheikh. Dr. Mona Sheikh holds her MBBS and PhD in neurophysiology, along with a master in health professions education. She has an advanced assessment certificate from Dundee and Famer Fellowship from Philadelphia. Additionally, she obtained postgraduate certificate in academic accreditation and assessment from Keele University, as well as the diploma in AI and Python programming. Currently, she serves as the Vice President for the Saudi Society for Medical Education. She is also the former head of the Research and Innovation Unit at the College of Medicine, Imam Abdurrahman bin Faisal University, since 2012. Dr. Sheikh has been a certified accreditation reviewer for the National Education and Training Evaluation Commission and a member of the Central Assessment Committee. Dr. Sheikh notable achievements includes founding the Medical Education Department and the Faculty Development Program with Interprofessional Essential Skills for Health Professions Education course, and establishing the Examination Center at the College of Medicine, Imam Abdurrahman bin Faisal University. Dr. Mona will be talking today about interprofessional education, collaborative practice and care in the Arab countries, roadmap, priorities, and challenges. Dr. Mona, the floor is yours.
Thank you. Thank you, Prof. Hassan, for this nice introduction. Thank you, Anik and KKU, for inviting me and for giving me this huge task of talking about the IPECP-C in the Arab countries, roadmap, priorities, and challenges. And believe me, it was not an easy job. Right, so whenever I teach, I've been teaching physiology since 1985. So whenever I teach a concept in physiology, I like to anchor it to something before, like anatomy, histology, even sometimes embryology. And we like also to extend into the clinical field. So when I wanted to talk to IPE, I said, what was the first spark? And I found in the literature in 2003, there was a very landmark report, an American report called Health Professions Education, a Bridge to Quality. Now, there was a clear cry within this report for the introduction of IPE and collaborative practice. And this followed two important reports which all of you have heard about. The 1999, To Err is Human, and the 2001, Crossing the Quality Chasm. So this, if we want to understand something, we need to see why it was first invented or thought about. So the reason for IPE and collaborative practice was to reduce medical errors. John will be upset with me now. He says, don't call them medical errors, call them adverse effects. So this was as early as 2003. Now, you've seen this model before several times, but what the concept is talking about is that if we look into our fragmented healthcare needs and we put them together and let 2 or 3 health profession learners learn from, with, and about, they will be in a better position to collaborate in the, while they are providing the care. And supposedly, this will improve the healthcare outcome and the patient satisfaction. So we will start with interprofessional education, and these are the qualities and requirements that we need. And then hopefully this will lead to an efficient and effective collaborative practice, leading to better healthcare outcomes. So I did an extensive literature review. These are the definitions. So the IPE is defined as a pedagogical approach where 2 or 3 learners from different health profession sectors, they learn from, with, and about. And the WHO definition is that it's an educational strategy where students from different professions, they come together and they learn about the professional identity, their professional identity, and how it interacts with other professional identities in the healthcare team. Collaborative practice is the direct application of those skills that we have obtained during the IPE training. So I made a comprehensive literature review, and I came up with 644 articles looking into issues like strategy. Mind you, I was only looking at the Arab countries. I was not to talk about the global, which would have been easier. So I looked into strategic roadmaps, implementation frameworks, priority areas, barriers, success factors, and most importantly, assessment methods and the impact, which is the theme of this conference. So we found a lot of things, that there are a lot of emerging initiatives within the Arab countries. There is a lot of significant progress. And to mention, for example, the Beirut, Lebanon early initiative in 2011, the Cairo initiative very close to that, and the GCC progress also. So I have written a chapter with Dr. Hana Zamel about the IPECP in the kingdom. In King Saud, for example, they have the mobile clinic, student-led clinics. In my university, we have done an interprofessional education faculty development program. We let faculty from 6 or 8 health profession colleges learn from, with, and about. And believe me, we discovered a lot of things. We discovered that pharmacists are very good with innovative teaching methods. We discovered that nurses are perfect in documentation, learning outcome achievement, writing a course report. So we are not the same. We actually learn from each other. And this kind of collaboration within those modules continued in between the modules when they prepared the assignments. Because there was a lot of interaction for 2 months in between the modules to prepare a document which was required for the course. The other initiative in my university was Tabahuth. It's a research project, interprofessional research project, where the students with mentors in teams, in interprofessional teams, they create proposals for the IRB approval by the end of the course. So this is what I got from my literature review. These are the activity levels by the region. Now, don't ask me why it separates Saudi Arabia, Qatar from Oman and Kuwait. But maybe the column would be very high. So GCC is really leading, but you can see a lot. Lebanon, Jordan, Egypt as also having a lot of initiative. The publication, distribution mirrors the initiatives. I'm not going to describe the initiatives because I think we have seen champions from each of these countries, and they are better to talk about their initiatives than me. So the strategic implementation roadmap is that we need to do an assessment of the situation of the healthcare needs, of the stakeholder mapping, and the resources. Stage 2, we need to integrate those IPECPC competencies within our curriculum. Stage 3, faculty development. This does not mean that faculty development should wait. No, we can start parallel. So faculty development is very important. I cannot stress that more. Training programs, developing IP competencies, and simulation skills. Now, stage 4, now we start implementation. And the key word there is multimodal. Use different methods. Use different modes of implementation of IP. And I'll show you why. Number 5 is the most important stage, assessment, measurement. Measure the impact. So in summary, needs assessment, curriculum integration, faculty development, implementation, multimodal hopefully, and then measure the outcomes. So the implementation models and examples are many. I don't want to go into them. And I just want to say that that successful models demonstrate diverse approaches. There is a lot of variability into the degree of integration of the initiatives into the institutional curriculum and vision and mission and PLOs and CLOs. So many of them were just co-curricular. And I want to say that, so this is the distribution by specialty. You can see there's a lot of nursing there, followed by physician, but there's also a lot of physiotherapy and social worker and occupational therapy. And I cannot agree more because these are the specialties that lend themselves to interprofessional interaction. So the success factors, you need system support. The whole system should support this kind of initiative. You need faculty and leadership, so we need governance, we need faculty development, we need champion identification, and hopefully a database where all the champions of the region will be there. We need educational designers, so we need to have a curriculum integration, we need to have multimodal delivery, and longitudinal exposure. So it's a cumulative kind of thing, and it needs to be sustainable. Implementation strategies, there should be quality improvement, and we need to take the feedback of the students, of the learners, of the patients, of the instructors, and the assessment methods. So barriers, there are educational barriers, organizational barriers, and this is probably the most frequent, scheduling, curriculum rigidity, cultural factors, hierarchical structures, resistance to change, and system-level issues. Is it really, I mean, we were lucky when we were asked by the NCAA to put the KLOs or key learning outcomes for medicine, because we had thought of IPE, that was 5 years ago. We had put IPE, IPECP in those KLOs, and we had put AI, so alhamdulillah. The Saudi Commission also involved us in this big consultation on the competency framework for the postgraduate, and we also chosen IPE as an important competency. So we have support from these frameworks. Challenges can be logistical barriers, curricular and structural, faculty and institutionals. This has been discussed so many times by previous speakers, so I will give you the actual results that I got from my papers. You can see here the barriers. Number one, this is a plot of severity versus frequency. You can see number one there is scheduling logistics. So everybody's saying we cannot schedule. The schedule is very rigid. Resources, curricular, then faculty readiness. This is coming like this. So the highest is on the right upper corner. The lowest is in the left lower corner. We need to take perceptions. So students' perceptions versus faculty perceptions. Students are for it. They are very enthusiastic and they positively see IPE and IPCB. Faculty, they say we understand what it's all about. We think it's a positive thing, but we need this, we need that, we need this, we need that. So faculty are a bit more hesitant. Okay. This was the general from all of these papers about that we're actually tackling perceptions. Now let's come to the important topic of the outcome. What were the methods used for measuring the impact? You can see there is one plot which says the usage frequency. The other plot is the effectiveness. So the first one in green is the pre-post testing, which tests for knowledge gain and skill change, which is at the second level of Kirkpatrick model. And you can see that it has proven to be effective. You can see on the right side, pre-post tests were used mostly, 90%, and they were 75% effective. So they show that IPE, CP are effective. When we come to these ones in pink, there are surveys that can measure the perceptions about IPE and IPE-CP by students and faculty. And you can see that interdisciplinary, interprofessional scale is being used 70%. The readiness interprofessional scale has been used 65%. And then the ACAS, which is used in the clinical, is 60%. But all three of them have showed efficiency or effectiveness of IPE and IPE-CP initiatives. Direct observation, which is at the third level, or behavior. You were talking about behavior. I think it was Barbara. So direct observation has also showed effectiveness, but it was used less, only 45% of usage. And I totally understand that we have a lot of hesitance as to the reliability and objectivity of these kinds of tools. Clinical indicators, now we'll come to the real talk, which is the tip of the pyramid. What was the patient satisfaction? What was the patient outcome? Was there a change? Yes, this was even used even less, maybe 30%. It's very hard to link, and you need time. You need to give time for that. These were the changes in attitude, readiness, knowledge, skill, and professional identity. These were the pre-post values for each of these characteristics in the literature review that I have done. And this shows you that the program format usage frequency, the type of modality they have used. So short-term workshops were the mostly used. Least was the research projects. So it was followed by simulation, followed by online modules. But if you look at the lower right corner, I do have a pointer, right? If you look at the lower right-hand figure, it shows that online modules were actually least effective. So from the point of view of the teachers and the students, the greatest effectivity was for clinical rotations, followed by simulation. So we need to really see what is working and what is not. And when we look here at the satisfaction, students also are highly satisfied by clinical rotation, followed by simulation, and then followed by the other modalities. So as I said, when we implement, we need to have multi-modality implementation. Online, face-to-face, blended, and use different kind of activities. I have spotted 20 tools to measure the impact of IPE, IPE-CP. 12 of them were fully validated, and they have been used in more than one study. This is a list of the 12, not the 20. So these tools were, some of them were class or clinically based, faculty assessment and feedback. Some of them were peer assessment feedback, and some of them were self-assessment and reflection. This is the categorization of these 20 tools that I have spotted. And as Wiggins and McTighe says, we need to paint a picture. So it's a collection of photos, of feedback, of comments and reflections, rather than a snapshot. And you're all familiar with the Kirkpatrick model. So what we have found is that there is reduced medical errors, adverse events, 77% reduction in that. There is decreased length of stay in the hospital. There is lower mortality rate and increased patient satisfaction. And what more do we want? So the enhanced teamwork, mutual respect, and role understanding. You have seen the scenario that the students have nicely made. There were lack of all of these things. There's collaborative awareness. Everybody knows where his role ends and intersects, and where the other healthcare team worker starts. Readiness for practice, so we increase confidence, foundation for real world, so they are clear of what to do and how to do it and when, and early interaction benefits. So let me go, so this was the story from 2015 to 2025. Now, what is the plan? So let me share with you this Gantt chart. If we start in January 2026, we need half a year for IPE leadership and SWOT analysis. Then we need a year and a half for curriculum integration and technology. Then we need 1 year for program scaling and sustainability plans, 1 year and a half actually, so we will end by June 2029. While this is happening, we need to be working on the policies. So the whole thing, by the end, before 2030, we would have accomplished a big step towards IPE and IPCB. And as you know, the 1 million project starts with a step, just one step. And the proverb, if you want to go fast, you go alone. If you want to go far, you go together. So this is my take-home message. We need to collaborate and go together and hold each other's hands. Prioritize IPE in curriculum development, invest in faculty development, in IPE and IPCP, design reward system to recognize IPE champions and activities, and finally, develop robust assessment systems for IPE competencies. Thank you so much for listening.
Thank you so much, Dr. Ramona, for this elaborative talk. And it is indeed a great pleasure to welcome the second speaker of this session, Dr. Hani Al-Ghamdi. Dr. Hani Al-Ghamdi is an assistant professor of health policy, health services, and health economics, and serves as the chairman of the Department of Family and Community Medicine at the College of Medicine in King Saud University. He's also an advisor involved in multiple national health transformation initiatives, focusing on preventive medicine, population health management, and health policy development. Dr. Hani will kindly be talking about the governance of interprofessional education and collaborative practice. Thank you so much, Dr. Hani, and the floor is yours.
Can you check the mic, please? لا, I think now it's working. طيب, أسعد الله مساءكم بكل خير. I'm so happy and delighted to be here today. And thank you very much for the kind invitation to attend this outstanding conference. الحقيقة كلمات الشكر والتقدير لا تكفي لكرم الضيافة وحفاوة الترحيب من اللجنة المنظمة ومن الزملاء جميعاً، وعلى رأسهم أستاذي الفاضل ومعلمي الغالي البروف محمد النعمي، الله يعطيه الصحة والعافية والجميع يا رب. So I will try my best to speak about governance in IPE CP. I've tried my best to be as simple as I can because it's quite complex to talk about governance in more details. So just before we dive in, I would like to just see where we all stand. So if you can kindly just scan the barcode. It's like just a warm-up to see the different responses. There is no right or wrong answer for these questions. So the first one, who, from your opinion, who you think makes the most important decisions about strategy in your organization? Interesting. So while we have different organizations and institutions, we can see the most common is the board or senior leadership. So moving to the next question, how confident are you that your organization practices good governance? Okay, we can see that somewhat confident or some not so confident come as a second one. The next one is, which of these is not a universal principle of good governance? I know my colleagues from medical education will criticize me for putting these options because it's the longest one usually is the most correct one. All right, so to keep you thinking, there is a short quiz. Also, there are correct answers, like in, at the end there will be no marks for this one. Oh, so were you able to join for the quiz? So the question is, which of the following is considered a hallmark of good governance? So I can see that the majority choose the correct one, which is clear rule assignment and transparency. So moving to the next one, good governance always requires either a single strong leader, ignoring feedback from frontline staff, effective feedback and evaluation mechanism, or minimal involvement by outsiders. Excellent. So the correct answer will be the effective feedback and evaluation mechanism. The final question is, more hierarchical structure always leads to better governance outcome. So do you agree or disagree? Is it true or false? Okay, so we have you who choose true. Perfect, mashallah. The fastest is معنا القحطاني, who is معنا. Mashallah, excellent, good job. Okay, moving to presentation objectives, actually I tried to make it short about 4 main objectives. So we'd like just to understand the core concepts of governance and its significance. We can explore specific elements and framework for governance in different organizations, different models and challenges, and different ways to build a stronger governance structure. For the previous lectures, the speakers addressed different things, so we will try to move through them quickly. So before focusing specifically for governance in interprofessional education and collaborative practice, I would like to just take a step back and to know what is governance. So this definition, there is a quite different schools who define governance differently. So I thought that a short video, it is in Arabic, but thanks for technology, I was able to translate it and add a transcript, subtitle for it, to define or give a brief definition of governance and why it is important.
الحقيقة في جلسة ودية بين رجال أعمال ورواد أعمال كان نقاش على مصطلح الحوكمة ومآلاتها وتطبيقاتها ومبادئها إلى آخره. خرجنا منه بكذا سؤال. حبينا يكون هذا المقطع مختصر بسيط اللغة واضح مباشر عن الأسئلة المنتشرة والأسئلة يعني الأساسية. الحوكمة أكثر سؤال انسأل وأكثر تعريف واختلف فيه في القرن الأخير. أسباب الاختلاف كثيرة بسبب النشأة، نشأة الحوكمة كيف نشأت على غير المعتاد. العادة الشيء ينشأ في القطاع العام ينتقل للخاص ينتقل للثالث اللي هو التطوعي غير ربحي. الحوكمة نشأت في القطاع الخاص، تجهيز الشركات لنزول IPO في شاشة في سوق الأسهم. يعني الاختلاف كذلك من أساس الحوكمة. يعني الحوكمة بدأت القانونيين يقول الحوكمة لنا، والماليين يقول الحوكمة لنا، والإداريين يقول الحوكمة لنا. الآن التقنيين مصطلح جديد الحوكمة الرقمية. من خلال البحث والعمل في كل هذه القطاعات أقدر أقول لك التعريف اللي اتفق عليه الجميع هو ضبط سلوك المنظمة فقط. أي كلمة بتزيدها عليه ستختلف مع قطاع كبير من الأشخاص. المهم لدينا أن الجميع متفق على شيء واحد اللي هي مبادئ الحوكمة. مبادئ الحوكمة متفقين عليها وتطبيقاتها، فنحن ماشيين في المسار الصحيح. الفائدة من الحوكمة كلمة واحدة بس، بل هي صارت قطاع مستقل الآن في الجهات اللي هو الاستدامة. ليش أسوي حوكمة؟ استدامة. مبادئي، إجراءاتي، آلياتي، تطبيقاتي، أنا أبغى أوصل للاستدامة. وصلت للاستدامة بأي طريق فأنا أعمل حوكمة بشكل جيد. مررت بشفافية، مررت بمراقبة، مررت بكل الإجراءات المتعلقة بالحوكمة، فأنا سأصل إلى الاستدامة. وصلت للاستدامة فأنا في الطريق السليم.
So I have to split here. So تقريبا هذا كان واحد من أفضل التعريفات الحقيقة للحوكمة بشكل عام. So هي ضبط سلوك المنظمة. So you can control how the organization behave. الهدف الأساسي والأسمى it is the sustainability. However, from the different definitions, I can also add that the governance can refer to the processes, the structures, and traditions. So it can determine the power, how the power is exercised, how we can involve and engage the different stakeholders, and at the same time, how we make appropriate decisions. When we talk about governance, there are several terms that I will go and repeat them over and over because I think these are the important terms that we usually use in governance. So when we see that it includes a balance between accountability, transparency, and inclusiveness. Accordingly, if we can do these things, we can ensure the organization function effectively, ethically, and with integrity. Also, when we hear that governance, we will think about the processes, the policies, the procedures, and so on, but it goes beyond this to include the culture, the leadership quality, stakeholder participation, and responsiveness to change. And effective governance create the conditions for trust, for organizational stability, risk management, and to finally achieve our intended goals. So this question, why it is important, why it's critical, as we said before, that we need to, the sustainability. This is the most important thing. So we can start different, one of them like the interprofessional education or collaborative practice. However, if we don't have a strong governance structure, we will not achieve our goals or be sustainable. So we can start with the problem during the way. So can we stay sustainable or not? Moreover, there are other things that make governance is very important. So making decisions should be ethical, transparent, and participatory. We must improve the accountability among leadership and staff, support optimal use of resources, and risk mitigation to build organizational credibility and trust with external stakeholders, and foster environment for continuous improvement. I think my colleague, Dr. Mohammed, and other speakers, they talk about the research and how different research and publication emphasize that if you have a strong governance structure, you will reach to better financial, higher employee satisfaction, and you can deliver superior outcomes because you have different institutions. We talk about education and healthcare setting. So once we have a very strong, or at least we established a governance structure in our institution, we will reach to better, we will be more effective and more efficient. The key principles, there are many of them. However, maybe the most important things that we might highlight on is that accountability, one of the most important key principles in interprofessional education and collaborative practice governance structure. We have transparency, rule of law, participation, effectiveness and efficiency, and finally responsiveness. So just a question to audience to think about. Think about your organization or work context. What governance principles do you find most challenging to implement, and why? So while we understand at least what is governance in general or broadly in a different context, how we can think about governance in interprofessional education and collaborative practice, there will be no major differences while we have the same principles. But what is the unique thing in interprofessional education and collaborative practice? One of the things that is important that it is a complex multi-stakeholder initiative, and it is bridging education and healthcare system, which usually works in silos.
5 minutes.
How 5 minutes? Okay. So without governance structure, effort will be fragmented, goals will diverge, and the progress will stall. Same as well as previously that we have, if we have this good governance, we can make appropriate decision, we'll be more transparent, we will be able to monitor and evaluate and engage all stakeholders. I was lucky enough to participate in this published book about novel health interprofessional education and collaborative practice. I and Anthony from the United States, and we wrote this chapter about governance. We've tried to make it as simple as we can. It is not mutually exclusive, comprehensively exhaustive, but at least it gives the most important or core principles and framework. So again, we repeatedly say that Define roles and responsibility is one of the important things and one of the core principles in governance. Develop shared vision and mission, because we have different stakeholders. Provide adequate resources and financial support, and finally create supportive environment. Especially there's a quote that I like so much that say, culture eats strategy for breakfast. So we need to understand our culture. We need a governance structure that can be applicable to our context and our society, our country. For the framework to be applied, the same core principles will be applied here. We've added that starting by leadership and accountability, which mentioned several times during these 2 days. We need a leadership and accountability for governance. We need a clear rules and responsibility and evaluation feedback to close the loop. And to ground our discussion on a real-life examples, one of them is Kingside University case study. I will not talk too much about it because it was explicitly described in this part 3 in the book. But I like how the different stakeholders were included, how including the Vice Rector for Education leading the strategy. There was internal advisory board and external advisory board to reach to the best that we can in our university. I think this was one of the important things that we thought about, how we can make a simple governance structure in our country. And fortunately, we have Dr. Hussein here from Saudi Commission for Health Specialities, because we think that we have Ministry of Education who will, the main institutions that we thought about as simple as we can, as a basic, Ministry of Education for curriculum and quality assurance, Ministry of Health for policies and regulations initiative to be implemented, and finally, Saudi Commission for Health Specialities are important for licensure targeting initiatives and monitoring and evaluation. However, it's quite difficult to just think about only three institutions, because there are multiple stakeholders that we need actually to engage and to define their roles and responsibilities. Almost done. So here are more technical and more advanced matrices that we used usually to know the different stakeholders. We can analyze them, and at the same time to know the RACI matrix about who's responsible, who's accountable, who we will consult, and again, who will be informed. The different challenges that have been discussed during this conference are a lot. Like we can think about fragmented collaboration, resource constraints, policy and awareness gap, faculty resistance, and some kind of solutions that we can suggest is to have strategic leadership engagement, faculty development and incentives, phased implementation, clear policies and communication, and intra-departmental committee integrated evaluation mechanism. And to advance these strategies, this conference is one of the examples of advanced strategies. So advisory groups and network, continuous professional development, structured evaluation and feedback cycle, flexible governance models, and finally, culture for inclusiveness and innovation. So a takeaway message is I can say that good governance is essential across all sectors for achieving ethical, effective, and sustainable organizational outcomes. In IPECP, governance creates frameworks for collaboration, drives improvement, and enables measurable impact when led by strong principles and adaptive strategy. So we always plan, do, check, and act. And we keep this cycle. Successful programs continuously evaluate, innovate, and involve diverse voices from leadership to frontline practitioners and learners, and continuous professional development, adaptive advisory structures, and inclusive culture are proven ways to sustain governance excellence. And to conclude, I think that true governance empowers every hand to shape the future together, inshallah. Thank you very much for listening.
Thank you, Dr. Hani. Very insightful, very interactive presentation. We are behind the schedule.
Please allow me to introduce our third eminent speaker. It's very long bio for Professor Naimi. I'm trying to cut it short. Professor Naimi is a graduate of King Saud University, Abha, and he is a fellow of the Royal College of Physicians and Surgeons of Canada, and got a master's degree in medical education in addition to a fellowship certificate in surgical education and research at University of Toronto back in 1992. He served as a director of General Surgery Residency Training Program from 2005 to 2007, head of General Surgery Division, Department of Surgery, King Saud University from 2000 to 2016, head of Upper Gastrointestinal and Bariatric Surgery Unit, Department of Surgery from 2009 to 2021. Professor Naimi received his fellowship degree from International Institute for Leadership in Interprofessional Health Education, FAMER, in 2017. He chaired the Advanced Laparoscopy and Bariatric Surgery Fellowship Program Curriculum Development Committee in the Saudi Commission for Health Specialties from 2021 to 2023. He chaired the National Committee to combat obesity, Ministry of Health from 2021 to 2023. Professor Naimi developed a novel joint program at Sultan bin Abdulaziz Humanitarian City in Riyadh, collaboratively with Bennington Biomedical Research Center at Baton Rouge, Louisiana, taking care of patients living with extreme obesity and disability. Professor Naimi is an author for more than 45 research papers and 3 books. His recent book is Novel Health Interprofessional Education and Collaborative Practice Program, Strategy and Implementation. Professor Naimi is an active board member. That was really an honor to work with him in the Saudi Society for Medical Education, in addition to many surgical societies. Professor Naimi will be talking about accreditation standards and regulatory policies for interprofessional education collaborative practice. Professor Naimi, the floor is yours. Thank you.
Thank you. It was a lengthy introduction, and we said no lengthy introductions. So my time will be cut short. Anyway, thank you very much, Prof. Hassan, for this introduction. I'm really happy talking to my mentors, my colleagues, and my students on a very interesting subject, which is accreditation standards and regulatory policies for interprofessional education and collaborative practice. So the objectives are definitions of accreditation and regulation and the difference between the two, rationale for accreditation and regulation, available accreditation standards, regulatory policies, and conclusions. So accreditation versus regulation. It can be used interchangeably, but if we consider accreditation for undergraduate or for pre-licensure, it's different from regulation, which is more applicable to licensing and post-licensing. So accreditation is a formal process by which a recognized body, for example, NCAAA in Kingdom of Saudi Arabia, the National Commission for Academic Accreditation and Assessment or Evaluation, that assesses and recognizes that a health professional organization meets applicable predetermined and published standards. Accreditation standards are usually regarded as optimal and achievable, which are designed to encourage continuous improvement and development of the institute and the individuals. Regulations impose external constraints upon the behavior of an individual or an organization to force exchange from a preferred behavior to a safe behavior. The rationale why we accredit it and regulate to ensure individual and foundational competence and assure continuous improvement and development, to make progress in health profession education and break down of professional silos, to make individuals and organizations responsible and accountable, and to standardize quality outcomes and improve the well-being for all as per the WHO. So we have available accreditation standards for interprofessional education and collaborative practice. We have the Canadian experience, we have the United States experience, we have the Australian experience, and we have the Arab world experience. So the Canadian experience, as you can see, it started governmental in 2004. Then there was a formation of the Canadian Interprofessional Health Collaborative, CIHC. The CIHC started making a framework that stemmed from the WHO framework published in 2010, led by Prof. John Gilbert. The framework includes 6 interprofessional competencies, which is mainly mix of education and practice. The CIHC also led the accreditation of interprofessional education projects, producing the Interprofessional Accreditation Standards Guide in 2011. The United States experience started in 1972 by producing the education for educating for the health team by the Institute of Medicine, emphasizing IPE and IPCP. The Interprofessional Education Collaborative Expert Panel was later established in 2009 and produced its famous report on the 4 competencies in 2011, which include ethics and values, roles and responsibilities, communication skills, and teamwork. The Health Professions Accreditors Collaborative was founded in 2014. The HPAC developed a guidance document for policies, procedures, and standards for IPE to develop, implement, and evaluate IPE approaches. The Australian experience also, they produced, they secured a project which was initiated in 2013, and this project led to the Health Profession Accreditation Forum and to embed the standards into the curriculum. Then the National Registration and Accreditation Scheme was published, and lately the published documents involve interprofessional practice standards and outcomes. But common to all, there is a framework for any standards that you need to establish or policies. In the Arab world experience, Qatar was the first Arab country establishing Qatar Interprofessional Health Council in 2009, aiming at designing an integration of IPE within existing health profession education curricula. The College of Pharmacy at the University of Qatar, led by Dr. Alal Uwaisi, led to the implementation of IPE in its curriculum. Oman established a steering committee at Sultan Qaboos University and published strategies to support the implementation of IPE. In Saudi Arabia, the Saudi Commission for Health Specialties was established in 1992 for regularity policies and licensure and practice. And the NCAAA was established in 2004 for accreditation of health professional programs with set of standards. Two major documents were published. Number one, Introducing IPE in Health Professional Curricula by Dr. Fallat and colleagues, and the book mentioned Novel Health Interprofessional Education Program, Strategy and Implementation. So what do we mean by policies, regularity policies? Oftenly applied to licensing and practice, while accreditation is more for pre-license or undergraduate. Regulatory bodies provide policy mandates to maintain high standards of practice, provide professionals with titles and scope of practice or privileges, supervise, control post-licensing training programs, and oftenly certify graduates. Regulating IPE and IPCP can be applied through healthcare environment or through health professionals themselves or both. Finally, regulatory elements can influence IPE implementation in pre-licensing curricula, and to be the IPE mandate to allow entry to practice, and IPCP mandate in the Code of Ethics. So in conclusion, each country should develop its own IPE, IPC framework of competency based on local needs in order to develop its own accreditation standards and regulatory policies for IPE, IPCP. Health professionals, experts must lead these initiatives to develop and implement IPE, IPCP accreditation standards and regulatory bodies. Universities and educational institutes are obliged to develop and implement whatever standards comes from the regulatory bodies. However, the accreditation and policies mandate for implementation of IPE-CP standards and regulatory policies should be mindful, not forceful, should be mindful, neither dictate explicit structures and content, nor dictate strict guidelines. It should be flexible, so people can accept and manage at all levels, students, faculty, and program. Thank you.
Thank you so much, Professor Mohammed Al-Naami. And if you may kindly, Professor Mohammed, join us on the stage, as well as the speakers, Dr. Hani and Dr. Mona. Would highly appreciate you to join us for this panel discussion. It's indeed a great pleasure to have these talks and presentations to sum up the subject when it comes to the interprofessional education, from the summary of the work being done that's presented by Dr. Mona. Probably she would have to catch a flight if she's not able to join us today. And looking forward to the governance with the great presentation and talk Dr. Hani have presented, and summing this up to conclude it with the accreditation and regulation, with briefing that through the presentation by Prof. Mohammed Al-Naami. If I may just kind of have a clear debrief, Prof. Mohammed. Today we are in 2025, yet we are probably moving forward in a very great steps. But I feel that we're talking about something that probably should be there for at least a decade before, which is interprofessional education. The main principle of those who work together needs to learn together. And when it comes to the practice, the physicians, as Dr. Hassan have said, physicians, nurses, and other allied health professionals, dentists, pharmacists, and others, working together, learning together in the postgraduate setting, What is hindering us here in 2025 that we have a plan that is to be achieved within the next 5 years before 2030? It's just my humble opinion. I think that's a bit of delay of getting things into the motion. I know that there are scattered practices. We heard from the presenters yesterday about individual, and probably today morning had touched on it, some individual universities that have went through much more advanced steps than others, locally or nationally, regionally, and internationally. But when it comes to the postgraduate setting, this is very kind of more solid. When it comes to the practice, this is very much of solid. But how much we are doing to prepare on the undergraduate level our colleagues so that they will be catching up on more advanced level rather than, just getting that scattered and having different experiences. If you may shine the light, we'll highly appreciate that, Prof. Mohammed.
Okay. Thank you, Doctor. Thank you, Dr. Hussein Al-Hussein. We are privileged to have you with us, representing the Saudi Commission for Health Specialties, which is a regulatory policies body. And really, interprofessional education and interprofessional collaborative practice should be implemented at all levels. And having the higher authority who dictates on standards and policies, they need to be with us from the very beginning. They should come down with us and see what we do with regard to IPE and IPCP. So they will make sure that those really need standards, those really need policies, because you cannot let IPE and IPCP do different from one place to another. You have to standardize the thing and make rules and standards that all will follow on that. And as I've mentioned today to some of our colleagues, that there are competencies that we did not address in our undergraduate and even practice level, which are lacking and missing. And these are what we call competency frameworks. So the Saudi Commission, the undergraduate medical education, they made the Saudi MEDS competencies, okay? And these competencies are also applied in the postgraduate programs. However, this needs tool to be indulged into the individuals and the institutes. IPE and IPCP are the tools to make people adopt these competencies. And then you can regulate it at the same time. So that's my hunch, including governance, as he mentioned.
Thank you so much, Prof. Mohammed. And that will take us to Dr. Hani, and I will follow up probably on what Prof. Mohammed have kindly alluded through. So is there any barrier towards the interprofessional education and interprofessional collaborative practice right now, from the regulations that we do have right now? Is there a real barrier towards moving forward through that? And does it need to kind of have an top-to-down hierarchical push to make this happen? And from your point of view, how can we indulge into that so that we can accelerate that implementation? Dr. Hani.
Thank you very much, Dr. Hussein. And that's a very important question, to be honest. And while there are multiple and many challenges and barriers, I would think about interprofessional education and collaborative practice that at the beginning we have a fragmented healthcare services when we talk about healthcare services in silo. And on the other hand, we also don't have an agreement in
educational level. So actually, before we start to bridge the gap between interprofessional education and collaborative practice, we need a governance structure started from each one separately. Once we have healthcare system or healthcare providers working on the same page, and same as well for people in the education institution, then we will scale this up to bridge the gap between them, and we can see how we can make who will be accountable, how the policy and procedures to be at a national level before that. So I think it is different phases. If we can start from education to have a clear interprofessional education, and on the other hand, if you have collaborative practice clearly in healthcare practice, and quite interestingly, the video that, mashallah, the intelligent student they made, it elaborates how we still have this gap. So once we have this at this level, we can scale it up to reach to the and bridge gap between both of them.
Thank you so much. So, Dr. Hani, from you reading through the regulations and the existing policies, do you see and do you visualize a barrier towards that? Or you think that these barriers probably virtual barriers or non-existing barriers, more marked kind of psychological barriers? How do you read that with the system and the existing policies when it comes to the education and healthcare services provision policies?
Perfect. The first one is we need actually a policy. This is missing before we start. Actually, we don't have a clear policy at a national level that can regulate how the collaborative practice or interprofessional education at universities. So having a national policy that is to regulate this practice and at the same time to be mandatory. So this is why we included the Saudi Commission for Health Specialty in our framework. So if interprofessional education becomes a mandatory at educational level and collaborative practice can be evaluated and monitored as a mandatory to happen, I think at this stage the national policy can, that we can start. Like currently we don't have a national policy to organize this.
Thank you so much. And with having Dr. Hassan Zarani with us, it would not be possible to I make the follow-up on what Prof. Mohammed and Dr. Hani have presented without hearing from Dr. Hassan, reflecting on what both colleagues have discussed, and then I will have my final follow-up on that.
Thank you. Thank you, Dr. Hussein. As I told you, as I mentioned in the beginning of this session, I am biased toward interprofessional education collaboration because we see it in real practice, really. Being an endocrine surgeon, we see the advantages when implementing this interprofessional collaboration, and on the outpatient setting specifically, when we see patients as a one-stop shopping clinic, doing ultrasound in the same sitting, doing fine needle aspiration in the same sitting, knowing the result of the biopsy taken. So we cut short, the journey of the patients in the hospital. So it has a lot of psychological impact on patients, in addition to the other parameters. So I'm biased toward interprofessional education. Interprofessional education is not luxury anymore. It's something we need to do, we need to implement for a better healthcare.
Thank you so much, Dr. Mohammed Hassan. I would like just to make a very kind of disclosure onto what I'm going to be making as a follow-up, yet prior to having any of what I'm going to be discussing adapted by any of the organizations that I may have affiliations with. So I do chair the Academic Accreditation Council for Health Specialties and the Education and Training Evaluation Commission, which eventually reviews all the academic accreditation review reports that are submitted by the reviewers and then reviewed at the accreditation committee. Then it comes to us in the Academic Accreditation Council for Health Specialties at ITIC. Then we make the final recommendation for the decision. But what I'm going to be discussing today, I don't have any clearance from ITIC to what I'm going to be talking about right now. I did chair the Executive Administration of Accreditation at the Saudi Commission for 6 years. I'm here as the Saudi Commission Secretary General Deputy. So I will just draw in a very brief manner, the anatomy of the education and the healthcare service delivery system. And I see today who's missing with us probably in this conference, and we probably need to get from the proceedings of this conference to the next, our colleagues from the Universities Affairs Council, who are holding many of the duties and the mandates of the Ministry of Education, and they are in that transformation phase. So our University Affairs Council, I think we need to be on board with us while we are making as proceeding from this conference. Our Education and Training Evaluation Commission, with the work, great work have been done over the past 3 years, and have witnessed how this goes forward through Jahiziyya, and most of us have seen the documents released through Jahiziyya. That's taking things from narrative accreditation standards that are mostly based on quality metrics to discipline-specific standards, and you cannot do that without having to clearly describe the key learning outcomes, that based on that you will see the program learning outcomes developed by the individual health faculties. So the KLOs and the PLOs, I think with Jahiziyya and the KLOs being set, approved, and escalated. The Saudi Commission for Health Specialties, any program is based on the royal decree prior to being established, has to be approved by the Saudi Commission, then feedback on the Ministers' Affairs Council and the colleges so that they can establish that program. And we do make sure that the interprofessional education is a fundamental part of any program that is newly established. So that's a step forward. Probably, and I will come forward, what probably is missing here that we can take it together forwards. So when it comes to the postgraduate, so that's the undergraduate, any program being established has to go, or modified has to go through the approval reviewed by the Saudi Commission. We make sure that the IPE is integral part of any new program or program being developed. On the postgraduate setting, if you see from 2018 till now, the postgraduate Saudi board trainer programs, IPE is a fundamental part for the critical care, for example, nursing diploma, working together with their colleagues from the internal medicine residency, those with the critical care residency, those with the cardiac surgery and others too. You see the programs are communicating towards each other, and there is set standards in the accreditation, program accreditation standard for each one of these programs that try to link that. Now, what's probably is missing, and I would like to thank you, Prof. Mohammed and Dr. Hani for elaborating, that's probably having a policy so that we can move all together the practices of the existing programs, because the new programs, when they try to develop and go through and having to get the IPE component part of it, but they don't have the existing programs proceeding with that, that's probably, you can accelerate that momentum towards the implementation by having a national policy. And that's probably would not be possible without, and I don't think that there is any barrier or mandate that the Saudi Commission has to push towards that, but we will be more than happy to make sure that we work together to develop that national policy with our colleagues from the Universities Affairs Council, our colleagues from the Education and Training Evaluation Committee, and the Dean's Committees, because the Dean's Committees right now over the last 2 years, they have been very much active into addressing all these issues. And the Saudi Commission for Health Specialties, and I probably have seen that over the last 2 to 3 years, we're trying to bridge that gap between the education system and the health provision delivery system, between the Minister of Education or the Universities Affairs Council and the Minister of Health and all other health care providers. So probably working together and proceeding with these recommendations from this conference, how can we develop the appropriate policy without over-regulating? because the worst thing we over-regulate. With the right regulation that have push everyone to move forward rather than having that disparity between new programs and others, and new programs would not move in that momentum if the existing programs are not. And I hope the next 2 years we hear in the conference, in this amazing work that you guys are doing, that we move toward the transdisciplinary professional education where we get our undergraduate and postgraduate health trainees and students learning with their law students and faculty, engineering, IT, ethics specialists, and others, where we can address more complex issues than us working in the same industry that probably should not have an issue that should be dealt with years ago. I think that's where we can develop that policy that does not only tackle the IPE within the health professions, but also tackles the transdisciplinary and trans-professional interdisciplinary collaborative training and practice. And I hope that we see that so that our graduates will be future ready, because the future is not going to be easier than the past. And we need to get them very well rounded on all other, not only the health issues, the non-health issues that will define how our future health is going to be. And that's probably what I can sum up the great presentations that you guys have done and how I see this moving forward. Thank you so much.
Marvelous. صراحة ما شاء الله. يعني هذه واحدة من one of the benefits of this conference, that we come up with such يعني action plan that we can proceed inshallah in the future. الله يعطيكم العافية.
Thank you, Dr. Hussein. I'm sure that you have really answered a lot of questions related to this. Very insightful comments from your side. I think we'll give one or two questions. One or two questions, okay? Dr. Mohammed Al-Mansour, okay?
يعطيكم العافية. أنا سؤالي للدكتور هاني، شكرا جزيلا على المحاضرة. I think right now in Saudi Arabia we have a lot of our institution, academic and healthcare institution, passing through governance journey. So my question to you, Dr. Hani, introducing such approach will sometimes be faced by resistant concern from those institutions that we are doing our governance right now. We are in the transition period. Is it the proper time to introduce this? Some institutions that I know that they said, let's defer this to the next strategic plan. So what do you think? How do you see it from governance point of view?
Thank you. Thank you very much, Prof. Mohammed. Thank you very much, Prof. Mohammed, for this excellent question, because it actually likes two sides swords. That at one side, as you've mentioned, now it is the most appropriate time to talk about governance, because this is what we are seeing and what we are working on in different in different institutions and organizations, not only limited to healthcare or education. So part one, yes, this is, I would say it is the golden time to talk about governance. However, on the other hand, we are in a transformation plan. So this sometimes make it a bit cloudy, not clear how we can establish a framework or governance structure while we still in a transformation. When we are talking about healthcare system, you might notice that Ministry of Health previously, it was the regulator, payer, and provider of care. Now with the healthcare transformation, the role of Ministry of Health is only a super regulator, while providing care by health holding company, and how the payer is Saudi CNHI, which is Center of National Health Insurance for the governmental sector. And still we are in this transformation. However, starting late better than none. So if we start at least or establish a governance structure for IPE-CP now, giving the different stakeholders we always can change, we always can improve, we always in this cycle. So as I've mentioned that we plan, we do, we check, and we act. So I think from the perspective of planning, we planned, and we still need to implement a governance structure by involving different stakeholders. And I'm so delighted and happy that Dr. Hussein mentioned the role of Saudi Commission for the Speciality, and they are willing. So if we can start with a national policy and we can share our ideas with different stakeholders and establish a governance structure that we can revise regularly, I think this will be the best thing that we can take, at least after this conference, inshallah.
Last question, Prof. Rumayyan.
I'd like just to thank the speakers, excellent actually speakers, Dr. Hani, Dr. Muhammad, Dr. Hassan, and the excellent summary by Dr. Hussein. The national policy has to be national, has to be global as well as local, what you call it, at the level of the nation. And I like the notion that it has to be continuum, and there is a continuum. There is an undergrads, then there is postgrads. And putting them as a standards, I think this is the start. A standard has to have an authority in order to be implemented at all levels. So this is what we have been experiencing over the last 20 years of the accreditations. So unless you have standards, you have a timely policy, what you call it, a plan in terms of every institutions or every programs when they are going to be reaccredited, so there will be an additional standards that they have to provide those evidence that they are implementing is IPE. And I think actually from speaking on behalf of if they let me from the Dean's committees, is that they already actually had there has been discussions about IPE and integrations, but in order to be fragmented and taking a level up to be standardized as a minimum standards for all programs to implement IPE and giving autonomy, as Dr. Muhammad is the mindful, you have a standard, but give autonomy to all programs at various areas in the kingdom. I think this is the way to go. Thank you very much, and I think this is one of the action plan was Dr. Hani was saying.
Okay, with that, thank you, Prof. Rumayyan. Thank you very much. It was really fascinating session. We enjoyed all the presentations. Dr. Mona, she is not here. She left to the airport. Her flight at 4. Dr. Hani was very excellent presentation, as well as Professor Naimi. I was very really happy to have also with me Dr. Hussein from the Saudi Commission, who enriched actually this session. So I hope everything is going to be implemented, inshallah, with collaboration of everybody in all sectors in the kingdom and the Gulf countries. And I will keep the floor now for Professor Naimi. I think he has some announcement. Thank you.
Thank you very much. Thank you very much. It seems that we reached as to conclude our presentations and panel discussions. Now, we were supposed to have a break with corners for the topic experts. However, because the morning corners of topics of experts were not really operational that much, and also because of the late lunch, we're gonna cancel the break this afternoon, unfortunately. However, feel free to move around and bring your coffee, tea, or if you like to eat something. And we will wait for the president of the university to come anytime to memorize and reward those who were working behind the curtains. Really, there were many people, including students, who need to be really thanked and addressed at the end before we leave this conference. Until then, please try to give us feedback about the good things that you have seen, you have experienced in this conference in order to keep up the good work. And also, if you have any things for improvement regarding the conference, future conferences, things that you think we will benefit from when we leave this conference, we will welcome all comments and all advices. So the floor is open for comments. Even positive, give us positive comments. يعني ما هو معقول إنه we did not do good to say you've done well or Doctor. I'm just joking. Can you give Prof. Zaid Al-Hamdan the microphone? Just one second, please. You will get the microphone.
السلام عليكم.
عليكم السلام.
طبعا أنا تشرفت بالتعرف على بروفيسور محمد والبروفيسور علي في قطر فيس تو فيس، وقبل هيك كنا أونلاين. وأنا عارف الجهد الكبير اللي قام فيه الدكتور محمد ومجموعته من فترة طويلة. نيابي عن نفسي وإذا بسمحوا لي السبيكرز، يعني صراحة جهودكم كانت رائعة جدا جدا من بداية التنظيم لنهاية المؤتمر، وإن شاء الله تعالى الريكومنديشن ونتائج المؤتمر راح تحقق تقدم إلى الهيلث كير تيم ولا اور بيشنت لاور نيشن إن شاء الله تعالى. فوجهة نظرنا عن المؤتمر يعني زي وجهة نظرنا عن الشعب السعودي دائما، بتحلى بالأخلاق العالية، كريم، برحب بالضيف وما بيعطي إلا الطيب، واعطتونا الشيء الطيب والوجه الحسن. ألف ألف شكر لكم على كل ما قدمتوه، وبارك الله فيكم، والله يديم على الشعب السعودي والشعوب العربية الأمن والأمان وتقدم الازدهار، ويحفظ لنا قياداتنا إن شاء الله تعالى، وألف شكر لكم.
Thank you, Prof. Any other comments, please? Doctora. We need things for improvement more than you've done a good job.
We must start with you've done a great job. أنا حابة أشكر كمان scientific committee for the planning and organizing the session and really managing to bring the academia, regulatory, clinical practice and education in a very well planned session with the activity, the workshop. So I must really thank everyone, especially the organizing committee. Maybe a minor recommendation for the future to have more small groups for oral presentations for participants other than keynote speaker. So this will bring in a lot of people to come and share their experience or a mini presentations for everyone. So thank you very much. Thank you.
Thank you, Dr. Ayman. We welcome our president of King Khalid University. And now it's time to reward those who helped us for the success of this conference. And really, what we will say and what we will offer will be not achieving what they have done as a reward. So if I may ask Professor Ali Al-Qahtani to come up and make the closing ceremony with rewards to those who deserve to be rewarded. Thank you.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، وأصلي على نبينا محمد وعلى آله وصحابته أجمعين. معالي رئيس جامعة الملك خالد فالح بن رجاء الله السلمي، يسرني في ختام هذا المؤتمر الدولي الثاني لاستراتيجيات التعليم الصحي أن أوجه رسالة لجميع المشاركين والحضور الكرام، فأقول مستعينا بالله إن التزامكم بتحسين واستدامة تعليم الرعاية الصحية يعكس رؤيتكم نحو مستقبل صحي مشرق، فلنعمل معا بروح التعاون والابتكار، ولنسعى جاهدين لنقل المعارف والخبرات لتحقيق أثر إيجابي يدوم بإذن الله تعالى. أشكر جميع المشاركين والمتحدثين على مساهماتهم القيمة، وأثمن جهود اللجنة العلمية المنظمة التي عملت كفريق لإنجاز هذا الحدث، وأشكر أيضا نادي الطب والإبداع وكذلك الطلاب المتميزين الذين كان لهم الأثر الكبير في تحقيق نجاح هذا المؤتمر. ونتطلع أن نعلن نتائج وتوصيات هذا المؤتمر، وأن تكون نبراسا لمستقبل علمي مهني يعكس تعاون جميع الكليات الصحية. وأترك لرئيس اللجنة العلمية أن يعلن التوصيات. مشكورا.
Thank you, Dr. Ali. Prof, sit down. Can you please post the توصيات, recommendations of the conference? I send it to them. Can you post them please? المؤتمر الدولي الثاني استراتيجيات التعليم الصحي المتداخل والممارسة التعاونية الفعالة، سد الفجوة وقياس الأثر، جامعة الملك خالد في أبها. توصيات. توصيات المؤتمر. معلش عشان أشوف زين. نعم، توصيات المؤتمر. التوصية الأولى إنشاء مركز متميز للتعليم الصحي المشترك أو المتداخل، تعزيز الوعي بأهمية التعليم الصحي التكاملي والتعاون بين الكليات الصحية، تطوير مناهج تعليمية متكاملة بين الكليات الصحية مع التركيز على المهارات العملية والتواصل بين الفرق الطبية، استخدام التقنية الحديثة والذكاء الاصطناعي في التعليم والمحاكاة الافتراضية لتعزيز التعلم التفاعلي وتوفير بيئة تدريبية واقعية للطلاب. Next slide. خامساً، تشجيع البحث والتطوير المشترك ودعم المشاريع لتعزيز الابتكار وتحسين جودة الرعاية الصحية. سادساً، تدريب الكوادر الطبية والصحية على العمل الجماعي من خلال تنظيم ورش عمل وبرامج تدريبية تركز على مهارات العمل الجماعي والتواصل الفعال بين أعضاء الفرق الصحية المختلفة. سابعاً، تقييم مستمر للمناهج والبرامج التعليمية لقياس فاعليتها وتحديثها بما يتناسب مع التطورات العلمية وحاجة المجتمع. شكراً لكم.
يسرني أن أدعو سعادة الأستاذ الدكتور عبد العزيز العمري لكي يعلن أفضل بوستر وأورال برزنتيشن وفق معايير تم الاتفاق عليها من خلال اللجنة العلمية.
طيب نكافئهم ولا بس كذا؟ أيوة.
بسم الله الرحمن الرحيم. السلام عليكم. صحيح. We are waiting for the slides. So there was a committee formulated to choose the best oral presentation and the best abstract. Myself and Dr. Rami Ghazi and Dr. Assam Mahmoud. So for oral presentation, the winner is Dr. Adil Mahmoud from Qatar. Dr. Adil is there for his lecture about potential of digital health and enhancing interprofessional collaboration. Dr. Adil Mahmoud.
تكرما معالي الرئيس إذا ممكن لإعطاء الزملاء الدروع والشهادات.
Can we have the slides for the best poster? Is it available or? No. Okay. So for the posters, the third prize goes to Dr. Hani Atawa from Arabian Gulf University, Manama, and his colleagues from Ismailia, Egypt, and from Ibn Sina in Jeddah. I'm not sure if, yeah, sure. If you can take the prize. The second place goes to Dr. Amuna Sheikh for her abstract about the impact of interprofessional longitudinal faculty development program from Imam Abdurrahman bin Faisal University, Dammam. Prof. Na'mi will receive the prize. And now the first place will go to Dr. Asma Abdel Nasser and her colleagues from Ismailia, Egypt also, and from King Abdulaziz University, Jeddah. So the title was Evaluation of Interprofessional Course on Leadership and Management of Medical Courses. Somebody receive it?
يسرني أن أدعو أصحاب السعادة عمداء كليات الطب في المملكة وكذلك في الخليج لاستلام دروعهم وأخذ صورة تذكارية مع معالي الرئيس، فليتفضلون مشكورين.
يشرفني الآن أدعو سعادة الأستاذ الدكتور مفلح القحطاني رئيس دائرة الاتصال المؤسسي بالجامعة فليستلم درعه مشكورا. Dr. Mefleh is one of those who, and his team, who worked behind the curtains, supporting all details of this conference with regard to tickets, accommodation, transportation, etc. Thank you. Also, for those who helped us a lot to make this successful, to make this conference successful, is Professor Abdul Latif Al Muhsina from the Unit of Conferences, Workshops, and Symposia. Anybody from his department here? Okay, I will take it instead of him. شهادة شكر وتكريم للأستاذ عبد الله العنقري، الشركة المخرجة للأوديو فيجوال المرئي والمسموع بهذا المؤتمر، فليتفضل الأستاذ عبد الله العنقري. ممكن أحد يستلمها بدل الأستاذ عبد الله من التيم؟ شهادة الأستاذ عبد الله. طيب إذا أنتم مشغولين فوق أنا باخذها بالنيابة عنه. Last but not least are those who helped in guidance on the videos and the our distinguished students, and I will read you the names. وهم الطالب ظافر زاهر البكري، الطالب سعيد محمد القحطاني، الطالب عبد الرحمن العمري، الطالب محمد الشهراني، الطالب محمد علي القحطاني، عجلان غرام الشهري، محمد علي الحياني، محمد الأسمري، معا مبارك القحطاني، محمد مبارك الشهري، وليد القرني، مازن خالد آل الشيخ، ومصعب عقران. فليتفضلوا لأخذ صورة مع معالي رئيس الجامعة، مشكورين على جهودهم في كل ما بذلوه لإنجاح هذا المؤتمر. يسرني الآن دعوة الدكتورة دانا الصانع, the host of the third Arab National Interprofessional Education and Collaborative Practice, which will be held in Kuwait, inshallah, next year. Can you post, please, her slides? Can you post the slides, please, of Dr. Dana الصانع? يلا تعالوا تكلموا هذا.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for having us here today. Dear distinguished guests, colleagues, Deans of the Medicine and President of King Khalid University and ANIC board member. As we draw the curtain on this remarkable edition of ANIC, we don't just share an insights or connection, but we shared a vision toward the future of collaborative practice in the Arab region. شكراً جامعة الملك خالد أتعبتوا من بعدكم. It's with great honor and pride that I announce Kuwait University will be the next home for the ANIC in 2026, inshallah. It's We believe that with strong leadership, world-class facilities, and a clear vision, Kuwait is ready to lead the next chapter of IBE in the Arab region. Now, let the screen come alive, showcasing the beautiful city of Shdadiyah, جامعة مدينة صباح السالم, and the strong commitment of leadership and the excellence that Kuwait University has.
ارتأت جامعة الكويت أن يرسم حرمها الجديد في مدينة صباح السالم الجامعية صورة مشرقة لبيئة تعليمية تعزز جودة التعليم والابتكار والبحث العلمي، وتثري التنوع والتفاعل، وتنمي خدمة المجتمع والاستدامة. وعلى شكل حرمين أحدهما رئيسي والآخر طبي، شيدت جامعة الكويت مدينة صباح السالم الجامعية في منطقة الشدادية على مساحة تبلغ 6 ملايين متر مربع، وتضم مباني الكليات الجامعية ومباني 3 مشاريع أكاديمية مساندة، ويقدر عدد المباني في الحرم الرئيسي ب111 مبنى، بينما يتم التخطيط لأن يكون عدد المباني في الحرم الطبي 28 مبنى. وتأصيلا لمكانة جامعة الكويت كجامعة بحثية مرموقة، جاء احتواء الحرم الجامعي على 1300 مختبر علمي وورشة علمية ليكرس الحرم الجامعي كواحة بحثية فريدة من نوعها. وتمتاز مدينة صباح السالم الجامعية بفصولها وقاعاتها الدراسية التي تتنوع في أنماطها وأحجامها، وتتميز بمرونة تجهيزاتها. كما تزخر ب7 مكتبات تعليمية صممت لتخدم أنماط القراءة المختلفة وتعزز الاطلاع والبحث. ولما كانت المسارح تشكل واجهة ثقافية وفنية، اعتنت جامعة الكويت بتصميمها لتكون إضافة ثقافية وتعليمية واجتماعية، ويبلغ عددها 15 مسرحا، من أبرزها قاعة الدانة للاحتفالات. كما كانت الأنشطة الطلابية والرياضية محور اهتمام الجامعة في سعيها نحو تطوير المواهب الطلابية عبر توفير مرافق متنوعة، من أبرزها الاستاد الرياضي الذي يتسع لحوالي 15,000 متفرج. وتضفي الحدائق والمساحات الخضراء طابعاً جمالياً لمدينة صباح السالم الجامعية، حيث تنسجم الزراعة التجميلية في الحرم مع مفاهيم الاستدامة والتخطيط العمراني الحديث، إلى جانب معايير متعددة، من أهمها استخدام نظام تبريد الضواحي الذي يعتبر نظاماً صديقاً للبيئة ويعتمد على المياه في تبريد المباني. وتتكون منظومة التبريد تلك من 3 محطات خدمات مركزية. لقد آمنت جامعة الكويت أن الاستثمار في التعليم المتطور وبناء الفرد المستنير هو الرهان لمن يتطلع نحو المستقبل، وهو ما دأبت عليه هذه المؤسسة التي كانت ولا زالت منارة للمجتمع.
Thank you and حياكم الله في بيتكم الثاني الكويت. We cannot wait to welcome you. وإذا ما شالتكم الأرض تشيلكم عيوننا وقلوبنا. And for those who haven't been registered yet, please use this barcode to be added for the ANIC directory to ensure a widespread of IPE event and activity across the region. Let's build a strong community by across discipline and across burden. حياكم الله.
Thank you, Dr. Adana, and we are thrilled really to visit Kuwait. And my advice, you go and start from tomorrow, the preparations, because it's really hard work. However, as a collaborative interprofessional education and collaborative sectors, we're gonna back you up and we're gonna work with you until the time of your conference. And please don't hesitate to ask any one of us to share with you any efforts that you like us to do by all means. Thank you. And at the end, I would like to thank everyone who shared with us the conference, who made lots of efforts to make this successful. And I hope by the end of this conference, we go back home full with happiness, energy, knowledge, and hopefully skills as well to plan and implement interprofessional education and interprofessional collaborative practice where we go back and work. Thank you very much. Now I'd like the barcode of the evaluation of the conference, as well as it is a feedback from you to us, and those who will fill the form, they will get the CME hours and the certificate of attendance electronically. Thank you so much. Have a picture for all of us on the stage here, please. Can you come up or down there? No problem. شكرا. You deserve everything.
بس عايزة أقول لحضرتك